Okay, so let me tell you a little bit about ASAP. ASAP stands for Accelerating Support to Advanced Local Partners, and we are a contractor with USAID, and our goal is to help them give funding directly to local partners. So we have two objectives, and that's to strengthen local partners as they transition to receive PEPFAR funding. Sometimes we work with subs, sometimes we work with brand new primes that have never worked with USAID, and we help build all of the internal capacity needed for compliance. And then we also prepare local partners to manage PEPFAR performance measurements and reporting systems. And it's, as those of you who are prime here, you know that that is a lot of work. So I just want to tell you a little bit about ASAP. We have worked with 60 local partners and 12 local government partners. We also work with government to government in these 4 countries. We have a lot of resources available. This is what I really wanted to share with you. If you go to our website, you will be able to see webinars. You'll be able to sign up for the newsletters. We do have communities of practice. We have training manuals online, and we have organizational assessment tools online. So I want to promote our website because we make everything open source for all local partners. So our webinars are very well attended. We've had 76 webinars, over 17,000 people joining. We're going to start them up again in January. The local partner meeting took a little bit of our attention away from the webinars, but we'll get back to them in January. We do have communities of practice in English, French, and Portuguese, and this is for local partners who join in on a Zoom meeting for a particular topic. They're co-hosted by local partners, and the co-hosts work with all of the members to determine the agenda. It's a lot of sharing of tools, sharing of experiences, networking, and they are, as I said, English, French, and Portuguese. We also have a newsletter which comes out, and now that you've signed up here, you will all get the newsletter, which will share information about our webinars. We have 3 manuals available: Board Leadership and Governance, NUPIS Plus, and Subaward Management. In the rest of ASAP 2, we will be developing one for strategic information. Again, all resources are available at this site. And that is the end of my part of the presentation. I'm going to turn it over to our consortium member. So ASAP has many consortium members, and today presenting is Right to Care, and they are our lead for strategic information. So over to you, Pedro.
I think we're settled. Welcome to you all. I think I would not repeat some of the electives that Catherine has already shared. So maybe we can actually dive into it. The serious timekeeping here. So I think we want to get through most of the elements that we need to do. So, sorry. Have we all sat out at the back there? All right. So I think back to the business of the day. I think we're going to take you through a whole lot of elements. More or less the whole data cycle, more to the context of implementing partners, and more or less what all of you here do for a living. The back, can we settle? Can we get everybody in and try to close so that we can get going? There's opening and closing at the back. Come through, come through, come through, come through. Come through, come through. Let's squeeze in the spots here, the 2 chairs at the front. And the 2 chairs here at the front as well, so there's space here. All right, we're good. Last man come in, could we maybe adjourn the door a bit? All right. There's one here. Say at the front and the other one there. All right. Anaki, you can give my chair to someone. Come through, come through. There's another there, chairs. There's a chair in the front. All right. It's a cool session. Come in, come in. There can't be a better session. All right. Come through. Yeah. Thank you. I think the gentlemen in the house, you can give the ladies, then you can stand at the back, the taller guys. All right. Ladies, there are 2 chairs in the front. All right. All right. I think at some point you're going to have to start, right? All right, okay. So my name is Professor Pedro Pisa. I'm the Chief Strategic Information Officer for Right to Care. And I think the essence of the 2 days that we're going to be with you is to take you through the different elements or the different themes that we think are very pivotal to making sure that we've got all have strong data-driven programs so that we can more or less facilitate precision programming and making near to real-time decisions based on data, right? I think that's the whole thing. I think you've had most of the elements that we'll talk about, but I think the key thing that we actually want to go through is actually how to operationalize it, how to set it up, the key pillars of things that are actually needed to be in place to do this correctly and effectively, right? Based on my experience, many people try to do this at ad hoc, and when you do it ad hoc without the correct understanding of how to actually operationalize it, it can be a very costly exercise and a non-cost-effective way of actually running a program, but actually you don't get back the benefits for actually using data. Then you get the people that don't work with data, which is more or less your technical people that run programs, not understanding why we're spending so much money on data-related systems, data management systems, but at the end of the day, there are a whole lot of efficiencies that are not actually being brought into the program by data, right? So the key thing about this session is we're going to be interactive, right? So I'm not going to speak on my own here. So you've experienced a good experience or a bad experience or something you're not clear about, but as we go through the different concepts and the likes, raise your hand. We don't want to leave everyone behind to say, how does this really work? I don't really understand this, but how did you actually operationalize? What were the challenges around it? So, and you get 2 answers from me. My understanding of what we did or did not do. So you get a yes or I don't know, right? And I don't know everything. So there will be someone in the group that is an answer to actually help facilitate the questions. So some things we can answer, some things the group can answer, but that's how we're going to run this workshop and session. Clear? So it can be, we don't want it to be a useless 2 hours of your time, right? So as we go through, if you're not following, stop me, raise your hand, then we go through it again. I could not be saying it correctly, then other people can say it correctly, but no one stays behind, right? Make sense?
I'm glad the RSO is going to do his presentation.
Oh. All right. So I'm seeing a lot of familiar faces. I think I've seen more than 15 people that have worked with me in the data space in the room. So I think some of the people, I think I'll be calling out to giving, so you can give us experiences for some of these things that are included in the workshop that we're asked to actually present and demonstrate, right? So I think in all essence, I think the key thing, if from each slide as we go, if you're left behind and you don't understand the concept of the approach, please raise your hand so that we can reiterate, or someone else in the group can reiterate in a better way, so that it's meaningful at the end of the session. And like I mentioned, it's not specific to Right to Care. We're just a consortium partner on ASAP, but what we're presenting today is more or less the correct pillars and the approach and how to actually operationalize the correct platform within your own spaces to make sure that you can have an effective or cost-effective data decision-making process with the data that's available, and how to improve efficiencies where applicable. And if you've got 10 Rand, what do you actually do with it? If you've got $10, what's the best thing to do with it? Because you cannot probably fund at times the entire data cycle. So how do you prioritize what to actually do and what to not do based on the funding that's on the table? So for most of the people that Yeah, so I think we can continue as they set up this, the slides or the decks back, right? So I think I think we're going to focus more or less on 4 pillars as we go through the work. I think the common language to everyone in the room is the monitoring and evaluation aspects. Then the second part, more or less, we're going to talk about from the M&E part, how to power strategic information products to be able to help us make decisions. And we're going to go through the process of how to actually develop the dashboards, operationalize the dashboards. Then we're also going to talk about the data analysis part, then at 2 levels. I mean, the first level is the generic automation of customized indicators, but also the deep dive analytics, like when do I actually think that it's essential to do deep dive analytics? How do we do it? What are the prerequisites or the needs that needs to be in place to actually, for you to be able to actually do that? As you know, that ASAP is capacitation, more or less mechanism. We'll also touch on the spots where we already know on the region where we've got the gaps and the areas that need capacitation. And under the analytics frame as well, we're going to talk more around GIS or geospatial mapping and modeling, and actually demonstrate from a live system tomorrow around how we have operationalized some of those elements for HIV work and TB work, but also for COVID work in the region as well. So we're going to do that as a live demo. Then we're also going to talk about the space around business solutions and innovations, and how that can enhance and optimize precision programming within our portfolios, I think. So mainly we're going to really center around that. Then at some point we're going to touch about the standardization and data governance structures, and how, as we come from different worlds, all of us in different countries, what's applicable in your world, what's applicable in Malawi is not applicable here, as an example, right? In Malawi, you're not allowed to host data on a cloud platform, for example, whereas in South Africa, you're probably allowed. In some countries, because of different POPI acts, you can do certain things. In some countries, you can't. So all that, in essence, we're presenting it as the blueprint. But as you listen, there are things that are applicable to your world, things that are not applicable, depending on the governance structure of data within your own settings and countries. Does that make sense? So I think that's in essence what we're going to do. Then we're going to do a live demonstration for some of the dashboards and what they look like, how decisions could be made from some of those angles. Then I've seen Chuka there, I've seen Dr. Mo from Manova there. Then they're going to give us a 2-3 minutes experiences of how they've used data as chief of parties in their programs, and we're going to try and capture some of the impact based on the work that we have done around how data can turn around efficiencies or things that are not working in the program. That is what we're doing. Did I miss anything? Right. Make sense? Right. Anyone left behind so far? Oh, we're good. All right. So we're gonna touch slow, understanding that some people that don't work in M&E or in programs, but they want to understand the approach to how data can be used. Because remember, the approach can be used elsewhere, right? We're just using HIV and TB programs because most of the people, that's what they do, right? So some of the things are generic to someone, but they're very new to someone else. So accommodate your friends and your cousins next to you. Happy? All right. So I think I've already explained the things that we think we need to actually attain from the session based on the knowledge, on the skills, and some of the practical sessions that we're going to do on the day. So I think it's a repetition of what I already mentioned. Then it's a 2-day session. Day one, then I think we're going to talk more about PEPFAR reporting requirements, the need for enhanced data surveillance. We're going to talk about the analytics frameworks, and we're going to also give examples of the different visualizations and dashboards that you can actually automate that we have seen that they can actually add impact. Then we're going to talk about the general data demand portfolio, and Nati is going to take us through the approach that we have used and we're training others to use around gathering user requirements and specifications. And when it comes to that, it's to just re-say that in English. You've got a team of people that run programs, right? People that work in facilities, people that work in communities, and the likes that are actually running the program. And there's certain things that they want to see to make decisions in the field and at work, right? Then there are people that actually sit somewhere in a little corner wearing glasses that actually have to develop these things, right? But they've got no understanding of what this program is and what it does. They don't know what these things mean, right? So in essence, you need a person in between that can translate the language of program people based on what they want to see and the requirements and what it should be, right, for them to talk to different stakeholders. It could be the Ministry of Health, it could be USAID, it could be CDC, and the likes. But they translate that information to people that we call developers, right? So these are IT people that then go and write this code in the back of a room or in a garage somewhere. Then all those cool things you see as a front interface, we've got a group of business analysts. Those are the people that do gathering user requirements and specifications in a particular way, right? So we're going to take you to some of their stuff of what they do, how they do UAT, testing whether the data that is being fed into the system is correct or is wrong, and the likes. So that approach is something that we're going to share, and some of the tools that are already in the handbook and the manual that talk to that element, right? Then the other part is the data visualization. So we'll talk about how do you even choose the system to power your visuals, right? Why do you get to say, oh, I want to use Power BI to power my visuals and not Tableau and all those kind of things? So all that visualization approach, right, and actually what you want to see, right, between the M&E teams and the people that are actually running the program, there is a method to the madness, let's call it that, right, of how you can, instead of starting from scratch, right, there's an approach, there are tools that can actually be used to be able to do that more efficiently. It doesn't mean that's the gold standard. It can be adapted to your own setting and world, but you don't have to start from scratch. Make sense? All right. Then day 2, which is tomorrow. So we're going to talk more around the approach and the methods for data collection, storage, processing, integration of data from different siloed systems, right? As you know that PEPFAR over the last 10 years, not just PEPFAR, all the other agencies, where when they fund a program, they also support the different systems that actually specifically talk to that program, right? So if that program ends, in most instances, after time, that system dies, right? So you got malaria has got its own systems. Then you got COVID has got its own systems. HIV, TB, they got their own systems. But even in the HIV, TB, prevention has got its own systems because there are particular programs that just fund prevention, right? But how do we integrate all the siloed systems to create one system where we can join all this data based on the uniqueness of one individual patient? Because you can actually get a patient is in a pharmacy database, then a care and treatment bed database, but they are also in the lab database, right? Because that's how you usually give care to a patient. But how do we join the data that's in the lab and the data that's in the pharmacy and the data that's in the care and treatment system to form one longitudinal record of that patient, right? So we're going to talk about that as well when we talk to data systems, right? Then we're going to talk about something that we call the ADC, online dashboards. ADC simply means automated data collection. So I think this is the more applicable thing to our environment or an environment where there is serious POPI rules and regulation about patient-level data. But what you can do is to actually correct at the point of collection, which could be a facility or community aggregated data that can be used to actually power your performance against a target or whatever it is that you need to power, but it's not right at a granular level or at a patient level, so that you protect more or less the patient information, right? Then I already mentioned we talk about advanced analytics and what's the essence of that, why the need of that, do you need to invest in that or not, and the likes. Then we're going to go further to another type of analytics that we call geospatial planning or modeling, where we actually give the essence of the where is the problem. So it's a location type of analysis that we'll talk about. I'm trying to be as simple as possible, but in my simplicity, some things could be very foreign. Just raise your hand so that we can make it simpler, right? We don't want to use words like modeling, like it's just, we lose one or two people in the room, right? Does that make sense around what the day and day two looks like? Right. So it's a good idea to come to day two, right? Right. So it all starts here, right? That so those that have been in PEPFAR for a while, they can attest to you that by each year the funding from when we started and to now, the funding is significantly going down. The partners that are actually implementing programs are actually reducing by the day. They can tell you that when we started, the number of NGOs that were doing DSD or community-led work and the likes, it has reduced. They can tell you that a lot of NGOs in the space have actually shut down and closed because they could not really sustain because of reduced funding over time. So what it then requires is, in that understanding of reduced funding, the need of what you actually need to do in terms of work, right, in terms of your performance, has not reduced, right? So that has stayed high, but you actually have a lower or smaller workforce to actually meet the performance that's required. So what it means that it needs a whole lot of sustainable approaches, right? Strong collaboration and sustaining the Ministry of Health to be able to take over some of this work. But the key thing is that the need for actually making sure that you can diagnose where the actual problems are within the program or the challenges in your performance, and the need for that data-driven precision programming is more important than ever, right? So for many people that are in NGOs, they can tell you one rule, right? You don't perform, you perish, right? That's it, right? So for you to be able to perform, right, and meet your targets with reduced funds, something needs to change, right? And from PEPFAR's world, that one thing that had to change was the use of data, right, for making sure that you've got tailored and targeted interventions, right, for the program itself. So instead of trying to do everything or trying to replicate or do things that are already working, maybe we need to focus the dollar that you get on actually reflecting and refining more enhanced targeted interventions for where the problem actually exists. And that you cannot do through dreams. You cannot do through, you can only do this by actually looking at the data in a particular way. Does that make sense? So we know PEPFAR championing the use of granular data, right, and generic and adaptable analytic tools, right, and a need for further insights within refining a problem that is articulated within the problem, right? There's also has been a big, vast channeling out of, they call them demonstration projects. Hope you've heard about them, which is more implementation science in a way, where there's a need for advanced evidence-driven, targeted or demonstration. A good example of that, it's for those that work within the HIV and TB space, the 3 and 6 months multi-dispensing work that has happened, right? So the clinicians in here, they care more about the patients than the funding. That's my understanding, right? So before we could just give patients 3 months and 6 months, we had to actually make sure that we first do demonstration projects or create the correct evidence to actually see that, you know what, instead of, by us changing our standard of care of giving a patient a month's medication or 2 months medication, are we sure that if we give a patient 6 months and we're not in contact with this patient for 6 months, we do not have inferior outcomes that actually come from our patients, right? So it means that you need to think of clever ways of how you actually provide that evidence, right? So back at the time, I think when this was starting, we did a blinded randomized controlled trial, which had a non-inferior design, right? To say that, you know what, if we give someone 6 months, right, the outcomes are not inferior to someone that gets a 1 month medication in terms of retention, viral load, suppression, all these kind of things, right? I think the one that was done in Africa, where I was one of the PIs, was a multi-study in Malawi, Zambia, the DRC, and Mozambique, and we showed that this thing was non-inferior. And from then, that was the evidence today that is being used for us to be able to say, no, let's do 6 months and 3 months multi-dispensing. So that talks to this demonstration project under advanced evidence data for targeting and the likes. That's just one example, right? But the key things, the example could be anything. It could be risk screening tools. It could be all those kind of things. But the idea is that for us to adopt them and them be done in other settings that have not done or shown the evidence and say, no, this is now standard practice, right? We need to show that evidence. Make sense? Then in line with ASAP core values and objectives around capacitation, right, there is a need to enhance data use. And this all comes with the whole change of management approach. I think some of the people that I'll call will give us experiences around that what has been their experiences around working together with different stakeholders, be it private partners, be it the Ministry of Health and the likes, to be able to look at the same data visuals and make decisions together with the funder, how challenging that has been. I like to give examples in the country that I'm not presenting. So I'll not give an example of South Africa. I think a good example is we had a DSD program in Zambia. So those that know Zambia, in the 3 provinces of Muchinga, Luapula, and the Northern Province. But with some of these enhanced surveillance systems, what it means is you can actually see what is happening virtually in a province of Muchinga around how many people they've tested today, right? How many people they've initiated, how many people they've, and all those kind of things, and how that program is performing, right? In the ease of it, it looks like a good thing, right? But you will see that to have that type of surveillance, right, from the Ministry of Health, from your funder, or from your other partners, to actually they see this is how you're performing badly and all those kind of things. It adds a lot of pressure to people that run these programs. For example, chief of parties. And we had a lot of resistance in Zambia because they're used to everyone seeing the data after a quarter. Here's how we've performed. Here's what, and all those kind of things. And they don't want someone to see what they're doing, whether they're performing or not performing on a daily basis, right? Because that has implications. The program is failing. What do we need to do? And all those kind of things. And it can be tiring to program people, right? So some things, those are the change management elements where you need to create the framework that we'll present around getting the correct buy-in from programs so that they understand that these are not there to police them in a negative view, but to actually enhance and improve efficiencies and actually making sure that we can realign our resources, be it staff, be it finances, to make sure that we actually use the dollar that we have to actually tackle the most painful area of the program. Make sense? It goes and relates to the HRH component that comes with our programs, right? To actually see some of the systems can actually, especially some of the tools that you can use as apps for testing and all those kind of things, we can actually see where the counselor is, right? Online, right? So if people say they're going to go to a bus or taxi rank to actually set up a station to do testing, you can monitor on a system to say, have they actually gone to this place? Are they there? How many have they done? Or the one person that they're testing, they've taken an hour or two, or they've taken 30 minutes, right? And the likes. And you can actually improve your capacitation and training around our counselors and all those kind of things based on the time frame they're doing and all those kind of things, or based on their hit rate about positives and the likes. But still, it can be taken as a notion that I'm under surveillance, right? Right, so I said I was going to be there at 8, but I got there at 8:30, but you can see it. So all those challenges, right, relate to the change management framework that is actually needed to make sure that this works, right? So you can have all the data systems, all the fancy stuff and all those kind of things, but if the people that use them can't use them, right, they feel like if they use them, these things can actually get them into trouble and the likes, then it's wasted investment, right? Because no one get to use it at the end of the day, right? And I think the people that have run these things have experienced this, right? Make sense? Right. Then I'll not dwell more to this. This is what you know, right? The reporting requirements and expectations for implementing partners. So you all aware what indicators are, right? And those come with different frequency of reporting, right, and at a different level, right? So I think this is more or less, as we get into the automated analytics based on the Mayor guideline, right? I think that's the essence that we want to talk about. So you will see that within your program, you've got indicators that you're given by your funders that you probably need to report on a quarterly basis, on a monthly basis, on an annual basis. Then those that have been in the space longer, they can tell you that in some programs they've got what they call high frequency reporting, that they pick up certain particular key indicators, and you actually have to report performance on those on a weekly or a bi-weekly basis, right? Based on the understanding of that cooperative agreement, right? But there are also indicators that we'll talk about as well that we call, let me go there back, that you call your customized indicators, right? Or your composite indicators in a sense, that you're actually using two indicators to compute a different indicator, right? The easiest one is they got this thing in HIV/TB programs that they call yield, right? So for you to compute the percentage yield, you have to get the number of people that are actually positive divided by the total number of people that have been tested, then you get this thing that they call yield, right? Make sense? Right. So you've used two indicators, right, to create an indicator. Does that make sense? Right? Then you got also things that we call process indicators, right? These are things that you're probably not required to report, right? So you don't have to report on these indicators, but they're an indicator that if you look at, right, they are rate determining indicator that can show you that the actual indicator you actually need to report on, right, if that indicator is red or green, it's got an implication on the actual indicator you need to report. Does that make sense? Right, in English, right? So I need to come up with examples. I always think I can come up with examples. The example of that could be, all right, could be those that do index testing. You have heard of index testing, right? So those that do index testing, for example, right? You might want to know the number of people from your from the primary index contact that you have elicited, right? Right, is the number, like, how many people? So let's say I'm the primary index, then I've got 15 other partners, right? And my 15 other partners have got 15 other partners, right? Of those people that are the index that have to all follow this 30, how many of these contacts have I actually gotten to, and how many of them are actually positive, right? So if I got 30 people that I need to follow up and actually only do 2, it means that my index final number is going to be poor, right? Because I'm not doing the facilitation correctly. So it's a process indicator. It's an indicator that can tell us, right? It's another one could be number of viral loads done against the number of people that are due for viral loads, right? So you want to have this suppression indicator. How many people are suppressed, right? But if you've got 100 people that you need to do a viral load on, but you only done 20, right? The number that you get is for the final outcome is going to be poor based on this process indicator or underlying indicator, right? People have warned me that I create new terms for things. So if you know the correct term, use that one, right? Right, I'm calling it a process indicator. But does that make sense, right? I've already talked, around this you know, like you got quarterly indicators, semi-annual indicators, and annual indicators, and that is part of your sign-off when you get a cooperative agreement, right? You know what you actually need to report on, when. Then we'll talk about the triangulation of all those things back to the data sources, right? Because remember, your funder needs to be able to audit whatever you've reported, whether it's quarterly, monthly, right, or annual, right? So there should be the audit framework around what is the actual primary source, where that number should tally with the number that you've reported, right? So as we do this whole framework for reporting, you got all those data management systems that you put in to add efficiencies, right? That could be at an NGO level. It's your own system that you've developed in-house. It could be something that we use. I think most of you are familiar with the DHIS too, right? It could be, but at the end of the day, all these data management systems, half the time, are not the audit, right, documentation when PEPFAR does an audit for your reporting. It always comes back down to the facility data source. Does that make sense? Right? So we then have to triangulate. If you say you tested 100 people at this facility, right? The primary data source in the facility need to be able to make sure that it is congruent with what you've been reported, right? Your system in-house, right, can actually probably report that number, but if it's not, right, at the primary site where the data is collected, it's an audit fail. That make sense? This is to just re-emphasize, right, the need for cooler ways of doing things, right, based on reduced funding that we're getting over time, right? This is just to give you, like, back in the day, look at how we used to aggregate age, just age. This is aggregation of age. Look at this craziness here, right? Right, right. So, yeah, these are our funders, right? That's what they do. Right, so right, so you'll be lacking one mechanism cycle to not get changes on. Those I'll give South Africa as an example for a change, right? Those that work in programs in South Africa, they can tell you that in every year you're gonna get 4 or 5 changes, right? That adds to the burden of reporting. So if you do not have these efficiencies, these ways of trying to automate these things, or cooler ways of doing things in a less burdensome ways, you will not be able to comply. Or you will comply, but as you comply, your strategic information teams, the only value that they give to you is only being compliant to reporting, and that's it. There's no further thing they can do, right? So they cannot create good SI products for you to make decisions. They cannot create forums for you to discuss data to be able to make decisions together. They cannot do deep dive analytics for an issue, right? All they can do is that they've got a serious reporting burden, right? I remember 2-3 years time. I remember when the high frequency reporting came into play, the teams that I used to work with, there was no Saturday or Sunday because we had to report on a weekly basis, right? The reports, right? Then if the systems were not in place to be able to actually feed that information. So what it then does is that you've got stretch teams, right? And what it then does is that because in 2015, you guys spent a lot of time also aligning this disaggregates to what actually is at facility or community level so that you comply to this. Then these guys, they just come from nowhere and say, no, cut that. We're now doing this. But the things on the ground or in the facilities have not been changed to be able to account for this type of disaggregation. It makes sense? Right. So it means that you have to go back in the facility, change the registers, the data sources, and the likes to be able to make sure that you comply. Right? So that is the challenges that all you guys face. Right? And the idea is that, okay, how are we, some preparedness in some of the changes that come from PEPFAR on a ad hoc basis, right? Based on what OGAC actually wants to see. Right, I think those are some of the things we'll talk about. But remember, on this element, I just use age, right? So age is one, right? We can even talk about the indicators, the redefinition of indicators, right? That May guideline, it's exhausting, right? But we all have to go through it in a way, right? But how do we just, add efficiencies to the new things that are coming from that May guideline to be able to add on to what we already exist and not recreating, right, all the time, because that's costly and that takes time. Right? Sava? All right. All right. I think this is quite lengthy. I'll try to just, you don't have to read this, so don't read it. All right? You see, I've got friends I work with, and when I tell them to change, it's where at times they don't listen to me. So it's wordy, right? So, right. So I think the key thing here it's why do PEPFAR partners need that enhanced management systems? So one, I think there's just an increased reporting need from PEPFAR that I've articulated to. Then I think the things that I was calling as process indicators are more coming up. Right, that they also want to see those underlying indicators that are not necessarily, the black and white indicator that you need to report. So you will see that with our stakeholders, they want to be involved more in our programming, right? So when I mean our stakeholders, I mean USAID, CDC, they want to be part of the decision-making process of our programs, right? They want to be part of the decision process that, no, focus on this. Oh, don't focus on this. Oh, no, do you need this number of staff? Are you sure? It looks like a lot. Why don't you do that and that? So including the Minister of Health as well. So when the Minister of Health is planning the HRH for the year, for an area like care and treatment, right, they want to understand that, okay, we've got a partner called ANOVA that is coming to work in this district, for example, right? What really are you bringing as resources to the table so that they can allocate their own budget for that district to complement, right? So that there's no duplication, right, of resources for once, but all that, right, without the correct HRH data systems, without the correct WISEN assessments, without the correct, they're very, very difficult to do, right? So that's why you see for most programs, there's fragmentation, right? You got the Minister of Health running with this own thing, you got the partner for that province running with that thing, and you got other implementing partners in that district that are running around with duplicating work. So we're not cost effectively using the resources for one geographic space correctly, right? Does that make sense in terms of planning, right? Then the key gaps within programs, right? It could be, the paramount ones at the moment is the case finding, it's the retention and the likes, just as examples. But the example is how do we triangulate the best practices, right, of a particular problem where others have shown evidence that they got a solution that actually works. So how do we triangulate the best practice from this implementing partner so that the other implementing partner does not have a headache around how to fix it? Someone else has already figured it out. Does that make sense? Right? So all that, ecosystem around sharing of how data can have impact, it's quite critical, right? So I think that's one of the key things that we thought, no, we're going to look at examples. So seeing is believing, I think. So we're going to look at selected key challenges that have been experienced in programs and the impact of using data to be able to go around, more or less, that problem. Right? Then, this is straight from a book, so you know this, right? So the need for, when you're doing data analysis and enhanced surveillance, the need for data quality, I think this is, we put it in here for your filing because you're going to get the slides as training material. So the completeness, validity, timely, reliable, precision, and the integrity of the data. More or less talking to the fact that if we go back to the primary source, right, is it the same things that we're actually getting, right? Make sense? So I think there's a whole data quality and standardized framework that is also in the handbook that you can go through, and the likes of how you can add efficiencies of quality at different levels, right? Simple things. The person that enters data is not the person that uses the data, you know? So it's things you know, but I think when they are put together in a handbook or framework, it's easier to implement in your own settings, right? Around to creating the different levels to make sure that data is correct, right? How do you triangulate data randomly to go back to the source to make sure that more or less our data is precise, right? Then this is what I've already spoken about around the ability of putting project stakeholders at the center of defining the information needs, right? So if data is put together and you've created different strategic information products or different visuals or different dashboards, there should be an essence to why, right? So the why, it's important for different people, right? So if you work in programs, you got people that are fixated and make sure that they perform, which are the people that actually run the program, right? You got people that are fixated with finances, right? And band rates, and making sure that we have enough pipeline of funds to make sure that the project carries through, right, in line with this timeline. Make sense? You got people, some of you, that are fixated on reporting, the M&E teams. Reporting, make sure that the data is compliant, to make sure that the data has got the correct integrity to be reported and is verifiable. Make sense? So all these people, their needs for data are very important, but the visuals that need to be developed for all of the different people are very, very different, right? I'll give an example. The program teams wants to know whether they are performing against the number that they got from USAID, against the number of people that they need to test in an area, right? So they're fixated. We're supposed to test 125,000 people in the quarter, right? So their leads wind down their targets down to a day, right? To say for each facility, this facility, you need to at least test 15 people. You need to test 10 people. If everyone meets their daily target, if we add it all together, we're going to have 100% performance against the quarterly target. Makes sense, right? So whenever they meet their teams, they want to look, how much did you do yesterday? That's their conversation. For this indicator, that indicator, blah, 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 and those kind of things. If they are doing well, great. What are you doing to make sure that you get these targets? The document, right, the things that are working for them in their area, right? Their best practice of some sort. If they're not doing well, right, then they say, oh, we're performing at 50%. Why? What could we do better? Do we need more resources? Do we need more staff? What interventions can we do? What are other partners doing out there that are making this work, right? So that they can turn that around. That's their obsession. If you look at the finance team, their obsession is it's different, right? So, yes, exactly, it's different, right? So they are telling you like, oh, we want to do an HIV testing outreach on Saturday and Sunday. The first thing they tell you is that, do we need to, right? That's finance, right? do we need to do that? And it's frustrating, right, that you have to convince these people, right, that are not in the trenches with us, that we need to do this thing. Then they're like, no, but you need to motivate. But why? What are you going to get back? And so their obsession is very different, right? Then you got the people that want to report on a weekly or bi-weekly basis particular indicators to USAID. They are obsessed about different things, right? All they want is numbers. How many did you test? Are you sure you tested this? Whether that number is meeting the performance or it's not meeting the performance, it is not their business. Their business is we've complied, right? We have reported on weekly, we've reported monthly, we have done the reports that need to go, we've done our piece of work, right? So you see the siloed approach of how we're actually working. And that's from one organization, right? But remember, within these facilities or communities we work, there's also the Ministry of Health with similar portfolios and similar challenges. Then you also have our funders, right? And you have seen how they've structured themselves over years. They've got similar things, right? They've got care and treatment. They've got, M&E, right? And they're phoning you every day on care and treatment. They're phoning you every day on this. They're phoning you every day on this. You're actually asking them, when are we going to do this work, right? So that's the award you're in, right? But half the time, we are all looking at different fragmented data, right? So your USAID lead from USAID is looking at a particular set of data, and they're somewhere on a Sunday watching football, and they're panicking, right? They're like panicking, and they're telling you, we need to have a meeting on Monday. Then on Monday, right, the chief of party from an organization is saying, no, but that is not our data, right? No, we are doing very well. These are our numbers, right? Then this one is saying, no, but I got this from the Ministry of Health where you work. So we are all, at times, we are all using different numbers, right, to push our pressure buttons. But more importantly, and what's more challenging is that we are not aligned around the actual targeted intervention that we actually need to do in the program, right? Because we are misdiagnosing the problem in the program because we are not aligned around what the actual data is saying. So that first element of the correct data, right, timely data, right? Oh, then, when I say timely, it's like, oh, this was the number 4 weeks ago, right? You know that, right? No, that's where we were 4 weeks ago. And like, where are we today? Then we're like, no, but we're not sure. We have 2. Then we create what we do every day. We create WhatsApp groups, right? Then when you create these WhatsApp groups, you're asking the person in that facility down the road, how many did you test? Then they say 9 today. Then tomorrow they're telling you, no, it wasn't 9, it's 6, right? We all have those WhatsApp groups, right? There's those because if you don't have those groups, then you're not running programs, right? Yes. Then your verification and your validation is to ask your chummy or your friend that, are you sure it's 20, right? Then they're sitting somewhere at a bar on Sunday watching football. Then they're like, it must be 20, right? Right? That's why that's why if you have not done this, then you're new, right? Right? Those that are not new, they understand this, right? So you're relying on one person there and all those kind of things. At times, you don't even have the resources to go and verify yourself. We had 4 facilities in Zambia once upon a time where we needed to get on this little boat. Remember? This little boat, right? To actually go and count this. And there's no network, right? So you gotta estimate, right? That, you know what? How many can they really test there? Then we look at each other, right? Right? Then you say, 9. Right? Right? And because you've worked in those areas for so long, right? The day that the tide is low of that river and you go, you're not far off, eh? It's like 11. It's like this and that and all those kind of things, right? But that's not the right way to do things, right? You're not far off. So the trends and the pattern, you can strongly more or less estimate, right? But the key thing is that then we now have to tell someone that has presented a particular challenge in Washington around the need for this and this. Then they now have to change their story to say, no, what we thought was a problem, no, it is not the problem. So we're continuously changing on a weekly basis the diagnosis of where the gap is in the program because we do not have timely and correct data, right? Which is a challenge. Then the other thing is that we cannot all get in one room as different stakeholders, be it the implementing partner and USAID and an NGO, and look at one pot of evidence as the correct truth for us to be aligned around solution. So we spend a lot of time, this is my experience, but I'm sure it's your experience, where the first hour and a half of the meeting, we are arguing about the number, whether it's correct or wrong. Right? And this has happened in Washington. I think I want to point the people that were in that session. Chuka there was in that session. Mo was in that session. When implementing partner say, that's not my data. Right? They actually say, that is not my data. What you're presenting there is not our data. I have our data here. Right? You get me? We actually need to stop the session. Right? But they submitted this data 4 weeks ago, 6 weeks ago. But you know what? And their conversation is correct. Now they have to tell the portfolio leads, no, we had to do a mop-up exercise. Right? So there was a lot of data, right, that was sitting in the files of the patient but was not captured, right? My Zambian colleagues can agree, right? That was not captured, right? And it's more than 5,000 people, right? So these things happened, right? So we did a mop-up. We hired data capturers. We trained them over the weekend. Then we had SWAT teams. They went into every facility and captured everything onto the EMR system. Then we reran the EMR system last night. Here are our new numbers. Right? So people have made decisions based on your data, but the data is wrong. It's not complete. Right? Now we have to reverse decisions, right? Based on emergency work that we all do. Right? Who's busy with mop-up activities for the Q4 final reporting? You are an efficient bunch, eh? Right? Right. So yeah. Because I think many people do not have enough resources, one, and enough coverage or enough data capturers to be able to make sure that they are represented at every facility. Right? So there's some facilities where you simply relying on the Department of Health staff, right? And not necessarily one of your own that is stationed there because you don't have the resources. Or you've got facilities that you've clustered because they're all close together. So you say we've got 2 data capturers that will look after these 6 facilities, right? So they can do Monday here, Tuesday here, and all those kind of things and stuff like that to make sure that data is complete or it's near to real-time data, more or less, right? Then when it's reporting time, all of us, we now want to go and count, right? So we go there and we do a whole mop-up element. Then all of a sudden the trend jumps so high. So monthly we're like this, then time to report, then there's a spike, right? Before the quarter reports, right? So we all do this. How do we mitigate that? And all those kind of things are what we're going to be going through tomorrow as well, right? Make sense? All right. So I think I've talked about this already, right? The custom indicators, the standard indicators, the contextual indicators. I think I called them process or underlying indicators and the likes, right? So we'll not repeat this. Then there's a handout that will be in the part of the folder that you can go through this that we've tried from the May guideline more or less for you to get an understanding that, you know what, for this indicator, this is the possible underlying indicator that you need. That gives you the litmus test, right? When I say litmus test is when you meet with a group, then there are certain things that if you do not get right, there's no way that the outcome will be right? So that litmus test already tells you that, no, the big problem is coming, right? That's the whole thing. It tells you already, right? So if you run your early missed appointments of people that are coming to pick up their medication on a weekly basis, right? When you see that trend, it can tell you already that, you know what, we've got a problem of retention that's coming. It's not yet here, but it's coming. What can we do about it? Make sense? Right. Another way of using this context or contextual indicators, looking for example, that will relate with everyone. Which is a true So in South Africa, Right to Care is an implementing partner at a DSD level for the HIV and TB care program in 2 districts. One is the one in Mpumalanga called Eslanzeni. The other one is in the Free State, it's called Tabo M, right? Interesting districts, but I think it's good to articulate this as an example. When they are doing index testing and soliciting, in this place called Tabo M, when they get to test all the index contacts, right, more than 95% of the people that they find through that index cascade already know that they're HIV positive, and they already know and they've been initiated, right, as an example. So all that work that comes from calling, sending a person to find this person, bringing them in, testing, and all those kind of things, eliciting contacts from all the indexes, right? 95% that they find already, I'm like, why are you calling me? I'm already initiated, I'm on medication already, and all those kind of things and stuff like that. Does that make sense? Right. If you go to the other district, right, about only 55%, right, actually know their status and been initiated. But the other 45% are people that did not know that they were positive and actually linked and initiated to treatment, right? But for you to be able to do index testing correctly, it's a plethora of resources and training from both the implementing partner and the NGO that's working in that space, right? So these things help you, like, do we want to spend our dwindled finances already doing a whole lot of highly scaled up index in a district where we're finding 95% of the people already knowing their status or initiated, right? Do we, right? Or, so what you call this? The fancy people here, so they call that the use of data to be able to do what you call district differentiated approach to programming, right? Not every size fits all, right? Approach, right? So if index is working well there, it is giving us new people that are positive to improve our TXU or our numbers to go up, so be it, right? But if it's not doing the same thing for you, you need to relook, right, your resources. So for just doing index, you're probably employing over 30, 45 people that are running this. Are they not better off doing something else that actually is a gap in your program than to repeat things that are not working, right? That's just an example of the ability of using data to actually do differentiated approaches to programming, right? Makes sense? Go ahead.
Yeah, thank you. My question is, who comes up with the conceptual indicators at what level?
All right, yeah.
And who should we have an agreement with to develop those?
Perfect. All right. So if you, with your M&E teams and your M&E leads, so let's start with the responsibility. Let's start. I've made sure that this whole thing, right, the people that are custodians to it, right, the M&E and SI people, right, but that change management is, if they do it alone without the program people, it's useless, right? Then what we then do is we then triangulate to say, guys, from the main indicators for our program, remember a May guideline is a thick book like this, eh? It's not everything that you report in your program that's in the May guideline. Are we clear? Right? So your program will say, if you're an OVC program, if you are a prevention specific program, if you're a TB specific, or you're both HIV and TB, right? From your contract, there is a set of indicators that you'll be told. People, you're going to report this weekly. You're going to report this monthly. You're going to report this quarterly. And you're going to report this on a semi-annual, then annual. That's, I think, our reporting frames, right? The weekly and monthly, how it usually works, for those that don't know. The things that they want to see on a weekly basis, or I think in a pace now you're reporting daily, I think. The certain indicators report daily, right? It's not a whole lot of, they can have 6 indicators that they feel they need to see daily, how you're performing, right? So imagine with your WhatsApp groups, huh? Right? You got 20 facilities or 100 facilities you run, and you got 100 data capturers on your WhatsApp group. Everyone needs to submit these numbers daily. Then you add them up together to make sure that you report the next morning for 4 indicators. Imagine the error. If 2 people have a network problem, or 2 people have got their kids sick and they've not come in for work, can you see how this thing can be distorted very quickly? Right? So you need agile systems that we'll talk about, right? But coming to your question, the contextual underlying indicators, sorry?
When you move away from the mic,
Oh,
to the right people,
oh,
attending virtually continue.
oh, all right, oh, they're saying I should not move. All right, okay, all right. Apologies for those virtual. I'm going to try to be as rigid as I can be, right? So I think the key thing is that the contextual indicators from that same May guideline. So you got things that are a requirement for you to report, but there are other indicators that talks to the issue, right? So a May guideline is like this, right? So it could be testing indicators, right? Then they say, okay, the number of people tested, which is the normal. Then they say, oh, on the testing, we want the yield, right? The number of people that are actually positive based on the people that you've tested. They can have an indicator to say, for those that are negative that you've tested, right? We want to know those people that are at risk, but they are negative. They want to know that number. And how many of those people have you actually sent to prevention services, like PrEP, right? So you in your program, you might only be required to report on one thing. But you've got all these other indicators that are there in the book that are part of this testing thing. You then have to go in there, your M&E teams, and select 1 or 2 indicators that are a good litmus for us to tell us that we're going to have a problem if this number is a problem. Does that make sense? Then after you do that as the SI or M&E team, then there are those people, you know, the doctors, you know, the clinicians, you know, those people, right, that work in the facilities. They're our chief of parties. They're the overall lead of the portfolio and the likes, right? They don't know what your TXML, things, right? Right? You're complicating their lives. Your job becomes to sensitize them that this is the key thing that we need to report on a monthly, weekly, whatever basis. But for us to be able to see that we need to do something different within our program, we also need to collect this indicator. This is our litmus test or contextual indicator that will tell us we're going to have a problem with this indicator. So every week, chief of party, this is the number you need to actually look at, not the outcome number. That will tell you that, no, we need to start do something different about testing, right? So it could be, it could be yield, right? Then it will tell you that, no, we're testing the wrong people. Can we have a risk screening tool that can actually categorize the people that are more at risk? Those are the people that we actually need to test, and not everyone, based on the funding that you have. Does that make sense? Right? So, to get this program right, you need people from different walks of life, right? You need the nurse, you need the clinical people, you need people that can strategize, you need people that can operationalize the intervention, you need people that can trigger the litmus test. Together in one place, right? We've got a better program to succeed, right? And I'll talk to you about the approach that we did when we're developing the concept of what we call situation rooms or epidemic control rooms around what I've just said, around putting together people from different spaces to be able to look at data from one source and be able to argue and articulate what the real challenge is, right? Make sense? Then together make decisions, and together, after they agree on an intervention, monitoring the impact of that intervention over time. Remember, your intervention does not mean that it will work, So if you've got a gap in a program, you're not getting enough positives in your program, right? Then you create a risk screening tool, right? You can use it for 3 months, and that number has not moved higher. It could be actually gone lower. It can talk to how the tool or the intervention was operationalized, or it can talk to no, this thing does not actually work in this setting. Then you need to be able to make decisions of scaling down an intervention that's not working or scaling up an intervention that's actually working, right? Does that make sense? Right. But back in the day, here's what we used to do for those that have stayed long in these programs. our friends, USAID, right, would only see, right, our performance and what we've actually done after 3 months. Huh? So we'll do what we're doing, go on boats, estimate 9, 10, this and that. But after 3 months, when you're doing the quarterly reporting, that's when they would see there's a disaster, right? Or that's when they see there's good performance. Let's learn about the best practices and try to copy that and do those in Cameroon, for example, right? So they would actually see data, even ourselves, that, are we sure this is how much we tested, right? After 3 months. So there was no enhanced surveillance for different people that are custodians to this program. So it means that they can only help us with interventions and decisions and solutions. When? After every 3 months. Whereas now, we sit almost every week with this USAID, Ministry of Health, to say, is this working? Is this not working? Let's shift this. Let's move resources to that and that. Let's not focus on this. We've already overachieved here. We're doing well. Let's do that and that as a group. Here's what it avoids. It avoids implementing partners taking all the responsibility. Remember, you're supporting ministries of health in the beginning, right? You're creating sustainable frameworks, right? Because one day you need to leave, right? You're suggesting sustainable frameworks for this to actually work, right? That's the whole essence of these programs, right? So at the end of the day, it's that sustainability, right? When day to day, there's no blaming when you actually don't get. So when you get to your end of the quarter and you have not performed, no one is surprised, right? There's no one in the room that does not already know the data, right? Why? Because on a weekly basis, we've been saying we're not meeting the index target. We have tried this, we have tried that, we have tried that, we have tried that, right? Everyone is aware. So we're not going after the end of the quarter and someone from Washington is saying, but have you tried this? Have you tried that, right? They are part of the process from the beginning. That's what data does, right? We can make decisions together, right? So I think I've answered your question, but I wanted to elaborate more on the actual approach. I think which is the essence of this thing. It's not the phantom display of this thing. I think the more questions is to actually talk about the how part. How do you actually do it? How the challenge is part of it. If the Minister of Health is not comfortable doing this and blah, 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 how do you navigate the space to actually make it work? I think that's the whole essence of the day and tomorrow. Make sense? Another question? Program people in the quarantine service provider. Yeah, so the question there is interesting. So I think I'll read it out so that we can all answer it, and I can give others a chance to answer. We need to hear another person's voice. The topic is quite interesting, but I wanted to know how to manage program people in the context, right? Service providers, they are more concerned with service delivery and far less interested in the data. They rarely read the ME and definitions of the indicators. True story, right? That is why when you present their data, they will say that is not their data. How do we ensure that they are on board and work as a team? Any ideas? The Stanley, right? I want someone to give me a practical example. Yes. Yes.
From a very layperson's objective, I think you've answered the question by saying, should I wait? Good morning. I feel like the question has been answered because you talked about the fact that I would say many people need to be proactive to educate us who don't understand MLE and also to make sure that they are ahead of us in terms of teaching what we should expect and what we should be looking out for on a weekly basis, monthly, quarterly, etc. Thank you.
Yeah, thank you for that answer. I think we got the gentleman and the lovely lady at the back. And there's my boss here as well.
Hello, thanks for the opportunity. And for me, I think it starts with data ownership. Ownership, which is all round from the people implementing or rather hands-on at the health facility and above the facility, especially the programs, teams, the TA. That means that those that are in the facilities must be able to understand clearly the indicators and their meaning. Secondly, it will be prudent that when it comes to collection of data, sometimes even those at above the site are also involved hands-on in collection of this data, because it even tells them how it looks like down there at the facility level. And then lastly, it will also be prudent to ensure that there's time to sit down together, look at that data together, so that we own it together. Thanks.
I think there was a lady at the back there.
Hi. Well, thank you for the wonderful presentation. I just want to give an example of where the people in M&E as colleagues and I am program, where we usually would have a diversity of thought in terms of agreeing, and then I will say, no, that's not our data. So where we usually don't agree, let us agree on what is reportable. Normally, let me give an instance. The M&E team will say, if this person has not been linked to treatment, we cannot report these numbers. If there's no linkage, then your total numbers of linkage to treatment of your new positives this week is 80%, is 90, well, say 90%, and I say, no, it's 95%. Because we are a community program, and being a community program, for me, it means that if I do a warm handover to my client to the health facility is responsible to put the client on treatment. Me at the community have completed my job. The M&E side will say, no. They have stepped in the facility, but they have not been initiated on treatment, so we are not reporting this week. So I hope you see the example I'm talking about.
I know the example.
Yes. So there'll be a lot of pressure, and this is where then we do not agree. So agreeing on what is reportable from the beginning always helps. Thanks a lot.
There's one guy, there's one guy. Thank you. Yes.
All right.
Chuka?
No, thank you very much. Good morning. So, on this example that was given, just to...
Please stand so that it's easier. Yeah, that's it.
Others did not stand. All right, but we he's taking chances. We work for the same company. All right. No, so just to say that for the example about the conflicts or disagreements, I think it's also about job design. I think somebody at a higher level should be able to design the job so that the different units will have somewhere they meet in terms of shared goals. So if the M&E officer should have some deliverables that is linked to the activities that are done out there in the field, just as the program staff should have some M&E indicators that are part of their KPI. But if people have completely different, never-ending KPIs, then those conflicts will be the norm in the workplace. So just something I wanted to quickly mention.
Yeah, one person there.
Can I come?
Thank you. I don't know if I have to stand, but I just want to add to what he said and what she said, which is very true. Firstly, on job designs, I mean, M&D would say, I'm M&D, and they have these indicators they want to report, and they have to report on a biweekly basis. sometimes programs will say, what are you reporting? I mean, you're reporting my data. And boils down to not really agreeing on what is being reported, and the people collecting and reporting that data not really understanding what that data is going to be used for, and how useful is it that we correct the right data at the right time and report it correctly, which all departments may have different understanding on. So really agreeing at the initiation, what are we reporting? How is it relevant to the indicators that we're reporting on is very important. Thank you.
Perfect.
Yep.
Next.
Thank you.
Go there.
It's too much late coming.
Yeah. You can start, sir.
Too much late coming from that side.
Yeah.
Yeah, I'm called Moses from Uganda, Makerere University Joint AIDS Program. Just supplement to what the colleagues have submitted towards the question. I think, like you rightly mentioned, we are charged with the task of supporting a system or strengthening a system that is accountable and responsive, and through data utilization. Now that's the cultural shift that we all have to work towards achieving. I don't know within what time frame, but I don't know.
Yeah.
But just share an example. I think for me, what I would like to see in terms of data utilization, especially for us who are local partners working closely with the districts and community structures, we really want to see a vibrant and responsive district structure. Likewise, at facility level, we want to see a vibrant and responsive facility structure, where the HRH is well optimized. And we are working in a system where we as partners, we've been forced to second some health workers, counselors, are not part of our structures. We have lay workers who are supporting psychosocial support and follow-up activities for different programs, TB, HIV. So how do we cultivate a culture of data utilization? And this is how we've tried to do it. We've tried to interest the teams, to functionalize the teams at facility level through their leadership structures, the health unit management teams, and the core technical management teams, to institutionalize monthly data review, performance review meetings.
Perfect.
And these meetings are not only supported by themselves, but you have the DHT members, you have the program teams, you have the regional mentors who are Ministry of Health oversight structures present in those monthly review meetings. Because we are talking of custom indicators as being a game changer in influencing the indicators. That's right. But we want to see them being identified and worked upon by the core teams at facility level. So that's the cultural shift I'm talking about. So we are really charged with a big task, but I think if we can work towards strengthening both the facility, community, and the district structures to be accountable and responsive, would have big gains. Thank you.
Perfect. Nice comprehensive answer. We have maybe the last two people. Three. You can start.
Thanks. So I'm Sam Perry from Malawi, Partners in Hope. So I think my colleague from Makerere addressed some of the issues. So I would just emphasize the points. Because I think it's that culture of them and us, which is to say the programs or the clinical and the M&E. But I think, for example, for in our sense, at Partners in Hope, we try to make sure that when we say programs, because you have the clinical implementation science and the M&E, so we are one team. So in this case, I think the structure is at the facility. When you talk about the data reviews, then everyone else is there and they're able to look at the data, and if there are discrepancies, they're able to address them. And some of them are the ones which you would turn into CQIs later on. And then that is available at the district level, led by the district program leaders who would also do the monthly reviews, who would use the same process to make sure that everyone is aware. And it is all sealed up by the central level where now the central office is going to be available in all these reviews. So I think the key components is to make sure that there's a forum for the both M&E and the clinical, the programs, to be available at the facility, district, and central. In that case, then you'll be able to achieve and reduce the gap which is there, which is the them and the us component. Thank you.
Totally agree. Thank you.
Yeah, thank you so much. My name is Juko Richard from Uganda. I just want to add on 2 components on what the rest have discussed. Number 1 is the component of the leadership. You observe that the leadership of any institution is quite very critical. That is if data utilization is expected to be, perceived the right way. But this basically begins with the component of the M&E teams, trying to educate the leadership to understand the different indicators and how best they can be monitored. Once this is very clear, then they will support and enforce processes of ensuring that data is utilized in processes of approval of, concepts or, some of these activities to go and support out there. So to me, leadership is number 1. Number 2 is the component of the continuous quality improvement approach. You observe that on so many occasions, teams at facility level or at implementation level, they need to be in position to analyze their data and then develop strategies through that small steps and incremental approach of the quality improvement innovations. So I really think that if sites can really employ quality improvement, then there can be a step in trying to realize the enforcement of utilization of data by the technical officers. For your take.
Perfect. There's a lady here. I think that's the last thing. Yeah. Wonderful contribution.
Thank you for the opportunity. My name is Charlotte from Burundi. My contribution is about what I feel like key in this process of data ownership first. I think when we are talking about education from M&E or ACI team, or for program people or for finance people, I feel all come from the program design, the whole understanding of the program design and the full involvement of both M&E, SI, and program, and even the finance team. To me, because some key contribution, some key tasks that need to make the data sustainable and come reliable, it involves also finance and the full understanding of both from leadership to technical. I think when we are designing tools for data collection, it means we need to have full understanding of the program design, from the SI team, so that we can come from the tools. And when we are designing tools, we understand we take care of all those teams, all those units that are involved in from data collection, that will be involved in reporting. Because if we are waiting from the SI, M&E to come and to educate program people, to educate finance people, that I think that there is a source of conflict and misunderstanding. Yes, there's key for the understanding of the key, the key indicators accordingly to each mechanism. There are some mechanisms that are typical clinical, typical of community-based, which I think need to have, not similar ways to understand. And when we are come for the period of reporting, we need to have involvement of all those people that are involved in through the whole process, so that the data are owned by the whole team. when we're saying these are not my data, it means there are some things that are missing, that have been, there have been a gap through the coordination, through the communication, and through also the process of data collection first, when we're designing tools. And there's a time when we need to realize that there is a gap. There is a data that is not being corrected correctly. And this will be a problem where it will come for the quarterly report. To mean we should not wait until the 3 months. If something needs to be corrected weekly, monthly, we should do so. And start to act at that time. Thank you.
Perfect. Can I pause now? Then we can add the different electives when you get it to the discussion forum. I think it's an exciting conversation, but I think as we go through some of the work and the different themes and domains, I think we're going to answer using real life examples of some of the key challenges that you're talking about. I think the key thing around getting people together, right, in one forum, how is that played out? And the key thing that I really want to articulate as I go through this is it's easier to present the picture perfect thing when things are now working, right? And the essence of this conversation is to take you through the reasons why it will not work, the reasons why it will be a phantom thing that we're excited about today and it's not sustainable, based on some of the experiences we've gone through and some of the experiences others have gone through. There was an element of leadership that is very critical that came up around the key. Remember, all your PEPFAR programs have got a hierarchy that has been established for the last 10 years from chief of party, deputy chief of party, technical specialists, and all those kind of things. If there's a lack of buy-in, how have we not navigated that element to make sure that use of data becomes standard practice? There was an elective mentioned at the back around HRH in terms of job roles and description and the overlap that comes with that, with ourselves and the Minister of Health as well. I think that's critical. And the planning component that came from him as well. So I think I've captured it, and I think as we go through some of the examples, we really need to navigate the challenges that others have faced and how have you navigated that space. I think that's the critical elements to go through as we actually discuss some of the challenges. And some of those things are contextual, right? The challenges around data governance, POPI Acts, and all those kind of things and stuff like that, what you can do and can't do with data, right? What's legal, what's not legal, right? And who are the custodians of that in the program to keep the attention to those things, right? Make sense? Yeah. All right. We've got about 15 minutes before break. Then after that, I'm gonna continue with 1, 2, 3 slides. Then after that, we're gonna do a live demonstration. But we got 50 minutes, so you can hold on a bit for 15 minutes. So that we have some tea and come back. All right. So I think we have talked about this, right? So I will not repeat the things that we have spoken about. Then in our setting, we have found the most 4 pillars of making this strategic information work really work. It does not mean all of them are a requirement, but the key thing is the monitoring and evaluation element. And I'll talk about the business solutions and innovation, data analytics, and GIS planning in short. I think what has been core and generic to our traditional way of running programs is the M&E piece. So I think we're very clear about M&E piece, indicators, right? So we know the M&E work, right? And measuring our performance against those targets and trying to make decisions, right? The business solutions and innovations, a mouthful. That's how we've named it. But what it is, it's a bunch of people, right, that should be able to guide the M&E, the programs, around, one, the correct IT infrastructure that is actually needed to actually have the correct systems running for us to have near to real-time data running, right? based on what we need, based on the budget that's at stake and the likes, right? So very few people are a jack of all trades, right? So you need to bring in the correct mind that can help us to make sure that the solutions that we pick up, right, the innovations that we want to do are feasible based on our infrastructure that you have as an entity, right? You might want to do a very complicated thing, but the framework of your IT infrastructure cannot support what you want to do. So this business solutions team have that mandate. The second mandate is that we've got people that they call business analysts. I think you've heard of what that word somewhere. What a business analyst does is, no, you're not. All right, I was about to say she can answer business analyst, but I'm thinking. So she's senior M&E, but what our business analyst people do is they work as the interface between the program needs, right? What the program needs, M&E needs, whatever it is that they need, and our developers, right? Our developers are the people that actually do the programming, right? They create the data warehousing where data is processed before it powers different dashboards. Or if you need to integrate data at a patient level from different systems, right? The thing that you need to do through probabilistic matching around, this is Pedro, I am the patient. I'm HIV positive. I'm in a care and treatment database, right? In my care and treatment database, what do you have there? You've got my regimen of treatment. You've got when I got diagnosed. You've got how long I've been on ART. You've got my TB medication if I had a co-infection. You've got my viral load data at times, right? Then you've got a different database that's got more data on everything that I'm taking from a pharmacy portfolio. You've got all my lab results coming from a laboratory system. But all those things are not in one place, right? The people that take, like me, take the patient and join all the data on the different system in a separate portfolio, right? Through what we call probabilistic match. Could be your unique ID, your name, your surname, your gender, and you join it. And what you actually have is you've got a very long longitudinal record of a patient from different sources. And you actually need that data at times to do deep dive analytics, where you got a bigger problem that is consistent within your portfolio, and you want to understand more insights around what's really going on around that indicator for you to have a tailored targeted interventions, right? But that analytics is not done within the system. It's done in your STATA things, SPSS things, where people do predictive modeling and the likes, but they can come up with insights to say, you know what? The most likely people that are not going to come up and pick up their medications are white males with beard, with this and that. We can phenotype it, right? With accuracy, right? So what it then does is our clinical teams can have a different enhanced approach when a client that is a white male with beard, with blue eyes comes in, right? Because you already know that this person is most likely not going to adhere to treatment. It's going to miss that. So that's how we try to use some of these value-add analytics based on what happens in the data management system for business solutions and innovations. Make sense? Analytics, I think you know the generic analytics. We've talked about deep dive analytics. The geospatial mapping and modeling answers the where part, right? Where, right? In essence, you've got a community team. That's part of your program, right? We're struggling with finding new cases, right? They've got a whole big city called Joburg or Gauteng, right? Where should they go and test? We're only 10 community people that are doing testing, right? Where should we go? Where do we get our best buck, right? So the geospatial analytics and modeling, it uses the different sources of data, but we can actually say, do not bother with this area. Do not bother with this area. Focus on that, right? So we've used this as well for, for the COVID program in South Africa, in Zambia, in Malawi, now in Namibia, where GIS has been pivotal as well to understanding the people that are more hesitant to vaccination or to vaccinating, where are they? So it then focuses and changes our interventions. Where do you need to do enhanced demand creation for vaccines, right? Which are these areas that you got the least uptake right, of vaccination and all those kind of things. So you got targeted, based on limited budgets, targeted demand creation, ways of doing things based on where you need to focus, where the gap is. So that's the GIS special modeling and all those kind of things, and we're going to talk about it, around how we've actually used that and the impact that it has done in different countries, right? So this does not separate the conversation that is pivotal, that I think the team from Uganda has really raised around getting the different teams, right, at different levels in one data forum to actually discuss. To discuss what is the question, right? Who decides on the visual that we need to see every week, right? What number do you want to see? What are the key indicators do we need to talk about to be able to come up with the correct insights around the program is the part that we want to get into, right? So, I created this slide when I was younger, so that's why it's busy. Right, so don't try and read. Please don't read, because I don't even remember what's there, right? But the whole idea around this is to just understand the overall framework and utilization of data, right? This part is inputs, right? These are different data sources. You are familiar with a lot here, right? You work with DHIS on a daily basis, right? You got care and treatment, EMR systems in your countries. You got PEPFAR-supported LIMS, right? Or your laboratory management information systems, right? There's some people that have got more fancier data around right, the evolution of particular diseases, be it TB, hepatitis, and the likes. So what it is, these are just different data sources that can be very specific in our systems or can be very general systems, right? But at the end of the day, there is a source of some sort for data collections. People now come to tablets, people have got apps that they use in the field and the likes. We've got HR, they've got their own systems, finance have got their own systems, GIS work have their own systems, the risk tools within your organization, they've got the risk management system for that one that you do where there is your risk officer comes and talks to the M&E lead to say what's immediate, this kind of thing, risk scoring and all those kind of things, right? All those are systems, right, that more or less, right, have been supported either by PEPFAR in the past. They're siloed, right, for maybe they were very specific to a program that was funded at the time, right? Some of these legacy systems have died because the program ended, right? Some of these things have continued, they've been adapted to other programs, right? But all of us, we come from a world in that country where you've got a implementing partner, they've developed their system, it works, someone picks it up, or USAID comes with a particular prescriptive system that you need to use, or the Minister of Health tells you this is the EMR system that you will use, right? Familiar? Right. But we're saying, in the current world we live in, we've got the ability, right, to make sure that data here can be, one, integrated at a patient level. That's a granular level, right? The person, there can be a Pedro in here, 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 and we can join this data to create one record of this person by using all these disparate systems. Make sense? Or we can actually power data at an aggregated level, right? It does not have to be a patient level. Aggregated means how many people did you test? 40. These 40 people, how many were male? How many were female? The way we stick to Mayor guidelines, right? How many were this age disaggregation, right? And all those kind of things. That kind of stuff. That's aggregated data, right? But in here, right, based on the different data mates that we let me not use the word data mates, based on the different themes we create, right? It could be automated reports. Remember, we try to automate our funders' reports first, right? That's the first level of analytics, right? You want to see the yield and you want to report it on a weekly basis and all those kind of things. You don't need your M&E teams to be running around and calculating it through Excel spreadsheets and through pivots, right? We need to be able to automate the reports for the funder, one. Then we've got a second layer of reporting to the Minister of Health, which is usually quarterly. We need to automate all those reports as well that go to the Minister of Health, right? So that we remove the burden of reporting of our teams. They can actually do more fancy work, right? Or more usefulness work. We need a machine to be able to do this, right? And when I say machine, it's not complex things. You can even automate this in Excel, by the way, right? But you can automate. You just input or put data here, whether it's at patient level or it's at aggregated level. You just press a button to enter it, then all those reports are generated, right? Then we can randomly then validate down to facility level, right? So this is the integration, transformation element here. Then the visualizations is what's key, especially for the data review forums that we're going to talk about after tea, right? That is very key. You cannot see every report, right? If we were to compute, how many reports are sitting in the knowledge center in total? I think over 200 reports, right? Because remember, your reporting ecosystem evolves, right? As the funding changes, the priorities changes, and all those kind of things, your reporting requirements change, your visuals change. But if you look at your entire repository of data visuals and charts, I think we've got over 241, right? We need a week to go through each, right? But the idea around when we actually sit on a weekly basis, depending on the stakeholders in place, to be able to see where we are, so that's the first thing, where are we with the program, performance, against key indicators. We cannot go through every indicator. That's the key thing, right? Our contextual underlying indicators, which are our litmus test to the outcome, where are we, right? So those particular static versus dynamic reports, remember, we run daily situation rooms. We call them situation rooms. Some people call them data review rooms. Some people call them epidemic control rooms. In this country, they call them nerve centers, right? But for us to be able to agree on the visuals, right, for all the stakeholders that are there, there's an engagement process, right, about the value add of each visual that is coming out from here. And we all need to sign that off and be aligned to be able to have the correct, what you call this, discussion forum. So we'll talk about that. Then the last part is the automation of all this. So whatever report that needs to go external and internal and all those kind of things can be reported. Then the last deep dive analytics, we can move data from this warehouse into another platform like Stata, SPSS, and do deep dive analytics, modeling, and the likes. So we'll pause here, then we can pick it up after tea. Reporting, dynamic can be a visual, it could be bar charts, it could be pie charts, it could be all sorts of fancy stuff that you want to do, right? But the key thing is all that can be processed here under different themes. Could be your first 95, second 95, third 95, prevention. So in your OVC world, you know the different themes that you can use to actually auto-generate the reports required for automated reporting. But also, you can actually then, depending on the need of a particular recurring problem, actually pull data from this centralized warehouse to actually do deep dive analytics or more value add analytics that can give more insights around that problem, right? We're going to give examples around some of those things, right? Then these are in our world, we've got a whole lot of different already customized reports and the likes. So it's a good idea before you start trying to develop new visuals or charts or tables. There's usually a catalog for this where you can just pull already that's existing. You see it in different ways. So instead of trying to waste time creating things, this thing has been done before. In general, when you're creating new things without a memo to read from, generally, I think it's a problem, right? In general, things have been done by others elsewhere. You just have to find the correct resource to be able to do it quicker, right? And starting from somewhere, not starting from scratch, right? In general, right, the teams online we have started, and We're going to sum up all the questions and the likes when we have an intermediary conversation. Then after that, we finish off some of the technical presentations we need to go. So I'm seeing the charts, right? I tried to summarize the typical challenges that I think you go through, or care and treatment actually goes through, the people that are doing HIV, TB work, whether it's at DSD level, or they're doing only technical assistance, or they're doing it at facility, or they're doing it at community levels, right? It's not exhaustive, right? But it's to give a sense of the different solutions that are out there, some that we've talked about, I think that are more common, that we can actually go get more insights around practical experiences from others, right? And I think the first thought is data not routinely used in real time, right? That's the first thing that came out, right? To actually improve how we actually manage the program, or how we tailor targeted interventions based on the gaps that we're actually seeing against our performance, right? So people talked about war rooms, people talked about data review forums, people talked about situation rooms, people talked about epidemic control rooms as a solution of getting different stakeholders, right, that are running a program into one place to be able to look at one source of truth, to be able to make the correct inferences that they actually need to make around a problem within a program, right? We tried to make most of the solution more or less have an impact at a patient level themselves. Some easier, some not easier. I'll try to explain that as I go through some of the solutions, right? Remember, every country has got some data governance or legislative approach around handling patient-level data, right? Back in the day, 2 years ago, someone can remind me, we used to be able to get client-level data from an EMR system in this country for care and treatment called TIER. We used to be able to integrate it with the NHLS data, which is more or less our lab data. We were able to integrate the same data with what they call the SYNC platform, which is pharmaceutical data, and the Links data app or community data to actually join one patient across all the systems. We had help from Microsoft Azure, because we used their space, because could allow to host on the cloud, and the computing power around every day when a dispatch is loaded in there, how it processes at the back end to create a longitudinal record and just power all the different visuals. Those ones that are only care and treatment, those that are pharmaceutical, but even those that are combination visuals, where you got care and treatment data, you got lab data on one visual and the likes, right? Then down the line, governance changes. All implementing partners are now regarded as third parties to data. New thing, right? USAID, PEPFAR, CDC, everyone need to sign off on that. Things have changed, right? It means that approach of using data died in a day, right? You don't comply anymore. As an implementing partner, you cannot have patient-level data outside the facility, right? But you're still the custodian of making sure that those systems work on the ground. Meaning that that integration platform of data from different sources in a second died, right? Then you had to be innovative to find new ways of how you can actually use aggregated data that is coming from facility level to be able to more or less find a way of having this increased group-centered care. When I say increased group-centered care, because you're no longer really talking about the actual one patient. Does that make sense? Right. Back in the day, with the phenotyping solution here, when you say client phenotyping, right? That word in English means we're using data that is made available to us based on the challenge that the program is saying we should be able to use the characteristics that we're collecting about the client to create a likelihood effect. Some people that are clever, they call it an odds ratio, but it's just a likelihood thing to say, what's the likelihood that if you're female of this particular age, you've got long hair, you've got this particular height, you're most likely going to be unsuppressed, for example, or you're most likely not going to adhere to your treatment, or you're most likely going to miss your next appointment to pick up your medication, you're most likely going to be lost to follow-up patient, right? So we're using patient's characteristics right? So you need a whole lot of data, overtime data, to do this kind of deep dive analytics to be able to actually do client characterization. Let's call it that, right? That's what it is, right? But what it then does, it then triangulates back to you program people, the people that are working in facilities. What we then do is we go in there and we create tailored targeted interventions around what we call maybe a risk group based on characteristics, right? Or a risk population based on characteristics. And we've got a different way that we handle those clients, right, instead of standard care. So as a clinician, so I'm working here as a clinician, right? Based on that understanding, that data has told me this and that, then you guys have created a new tool to say, you know what? If this person exudes these certain characteristics, you know what? You need to tell them more about the importance of adherence to treatment, right? It makes sense. So we then actually, instead of doing that for everyone in standard care, because there's no time, there's no resources, and all those kind of things, it's more targeted to the people that actually need it than the people that need it. Who has ever experienced a point where you following up lost to follow-up patients, and you phone them, then they're like, dude, you're telling me that I did not pick up my medication last week, but I was there, I picked up my medication, I've got all my medication. Why are you calling me? Right? Who has experienced that? Right? You've experienced that, right? You've experienced that, right? Then eventually they block you, right? Because they block, like, yeah, right. So if I was a patient, I would do the same, right? They're not organized. They don't even know that I was there, right? They don't even know that I went there, I picked up my medication, but they're phoning me, they're telling me that they're sending a community health worker to my house with my medication. Like, are you out of your mind, right? And maybe people have not disclosed wherever they are and the likes. So that's the essence of trying to make sure that we can actually have a way of having a good integrated data warehouse, that systems talk to each other, right? So if the visit is just for pickup and I don't have to see a clinician, right? Somewhere, somehow, in near to real time, right? That information that I've gone and I've been fast-tracked, who's running fast-track interventions for clients that are, that we're looking after to not stay in queues, right? So that we can fast-track them, they pick up their medication and go. If that data does not filter to certain people, right, then this patient is being called next week, right? And being told that you do not pick up your medication, whereas they are there, but there's a lag in our systems. That data filters and eventually has to go into the patient file, right? Another thing about governance, who in their countries have the rule, like in South Africa, Zambia as well, Malawi as well, the patient file can only be completed by the clinician, right? There's no data capturer that can write anything in the file. There is no other M&E person that can write in the file. It's only a clinical person that it's writing the file. Who's got those rules, right? So South Africa's got those rules, right? So data people can't write in the file. So whatever your findings, whatever it is that needs to then be corrected in the file that you have found, you still need to convince the clinician to be able to update this in the file, right? So that synergy, right, around the efficiencies is critical, right? Because at the end of the day, when we do the audits, or when CDC or USAID does the audit, right, the random selection comes down to files, right? That's how it works, right? So for many of you guys, your audit is based on the EMR system. What's in the EMR system is what we perceive as true, right? So if you tested or initiated 20 people and you only captured 15 files into the system, your TXU is 15, not 20. The other files that are not captured are not part of the audit. Make sense? Right? That's why you guys, when it comes to reporting, you're all doing mop-ups, right? The reason for your mop-ups and all those kind of things is to make sure that all your files are in a system that is auditable, right? So when we come there, we run your dispatch of your file. The number that's there is what we expect is what you have reported, not the other 15 files that are sitting in the senior nurse's office and they're not yet captured, right? If those are not captured in time, they are not part of the matrix that we're reporting on. Make sense? Question? Right? So we've talked about epidemic control rooms, right? Then the digitalization element and scale up of EMRs. I think that's standard, and that's what we'll talk about as well. But in some places, there's still countries that are still even battling around do they actually even have the EMR system in the first place, right? And we'll share some of the work that we've done in other countries where we have actually gone there to actually support the synthesis of EMR systems or also the scale up and optimization of them, right? We've talked about centralizing data or possibility of integrating data in one place, right? Based on our disparate systems that we've had over the years, right? And how can we integrate that data together, right? And here I've only talked about one method because that's what we do, right? Around pulling data from different sources, housing it in a particular space, could be an Azure platform. For some countries that don't allow data to be on the cloud, like Malawi, right? So all patient level data is not allowed to be on the cloud. We can actually integrate that actually on a server, right? And it can be hosted in country on a server, right? Another thing that we thought we could just talk about is the digitalized viral load tracking. So I think the key thing around the challenge was long turnaround times, right, for viral load results, right? And the gap that we've seen in many countries around this was for clinicians to be able to action. So maybe for those that don't work in the space, maybe let me give the correct practical example. So patient Pedro comes in, which is me, HIV positive, has been on medication for 6 months. I'm due a viral load draw, right? The first thing I get to the facility, you do what you call demand creation of viral loads from the provider and from the client perspective. But I can tell you with many patients, the providers even forget. It's actually the patient that actually has to reiterate that I'm due my viral load, right? And that's some of the training and capacitation that our clinician needs to actually learn, right? So they're running the numbers, there's a big queue out and all those kind of things. Half the time it's up to the patient to actually remember that they due the viral load because it's on their card in all your systems, right? What then happens is you draw a blood from me, right? Whether it's, okay, let's not do technical terms. You draw a sample. The sample needs to go to a lab, right? So there's transportation involved. When it gets to a lab, someone needs to be able to say that it has been picked up, it's been processed, right? Where in the station is it, and is the result yet, right? When the result is there, you've got your partners that you have, you know, Riders for Health, all those guys, right? Then they put your results in a little bike, right? Then they hit the bike up the mountain in Mchinga, Malawi, then they bring it to the facility, right? In the facility, right, it's taken by the receiving officers, it's stationed in a little box. Maybe after about 3 weeks, right? Because there's a backload and all those kind of things and stuff like that, this thing then actually tries to get to the file of the clinician. So when it gets to my file, I look at the clinician, then I realize, not suppressed, clinical outcomes not good, the creatinine looks like this, and the likes, right? Then from there, if the resources are there, that's when we can actually probably contact this patient to come through. And the turnaround times that from, I will not mention countries, they could actually move from 30 days, right, to 65 days until a patient is contacted when they've had an unpleasant outcome. So what's happening out there when it comes to epidemic control? They have partners, right? It means that there is perpetual increase in the number of incidences in our community because this person is unsuppressed. You understand the problem, right? So from a digital space and SI space, there are various tools. I mean, we have implemented in Nigeria, in Malawi, in South Africa, through the NHLS, and it supports the eLabs app. So what it just does is it's a clinical laboratory interface. It tracks whenever you got the results immediately. They actually go immediately to the service care provider, the clinician that's looking after the patient, and we can actually operationalize what we need to do. The results can come 2 weeks later on that little bike, right? But we've already done what for the patient, what we actually need to do for the patient. Does that make sense? The key gap we experience is also the clinicians, right? Our people, right? So they can exaggerate how busy they are, you know them, right? Right? So you can, so that change management of being able, right, to use data from, because they also, people don't like change, in general, all of us, right? As long as the change does not feel like it's benefiting my load of work, right? I'm not really interested. One, if the change seems to actually show the principles that I'm not working as hard as I should be, I don't really like that change, right? So those two things are very important through the leadership, right? To actually steal back that the value back to the client, right, is the critical thing, right? And it sounds simple saying it, but I think the operationalizing part of it, without the leadership being pivotal to it, is almost fruitless, right? I think we've touched on all of them, right? Then I'll not talk much around, so this is a simple way of, at an aggregated level, of how you can automate data collection and reporting in its most simplest form, right? Those that work at the facility, it could be community, right? Could be DSD specific work, could be TA work, right? You've got an automated, customized email that is sent to an M&E officer at the facility, or a data capturers, or whoever is the custodian at the data level of that facility, right? So it goes out at a particular time, right? Could be 4, could be 4:30, before they leave, right? The template is captured, right? At an aggregated level. I'll give you an example. We tested 20 people, 10 were male, this were female, so it's already, the template is already there. How many were males, females, how many were this age groups? It's a tally, right? Let's call it a tally, right? That's what you're doing, right? How many were initiated on same day? How many were not initiated on same day that need to be followed up? Whatever it is, right? It can be daily, it can be weekly, depending on how you run your data review forums, right? So we have in our DSD programs a template for daily, because we don't want to collect a whole lot. We've got a template for weekly and a template for monthly, because in the different forums weekly, we've got different people, right? And I'll talk about that as well, right? But the key thing is that in some places, like South Africa, they can do this online, right? Then they just say, submit a button, or they've done, then it all goes into this centralized place. Then it automates all those reports and dashboards and all those kind of things, right? In some places, we don't have that luxury. It actually goes in as an email. That's what we used to do in Zambia for the last 3 years. We've just changed that as IT infrastructure has improved in the country and the likes. It used to go as an email. Then they send the email back. Then the email is more or less rerouted into this integration warehouse. And in the back of this integration warehouse is your pre-programmed analytics, your equations, your this and that, your calculations, and all those kind of things. So you just feed in a number, right? Then they'll tell you what your yield is. They'll tell you what your TXK is. They'll tell you this and that, right? Based on your BSI, those business analysts' conversation with the developers. Make sense? Right. So you don't have to worry about that. Let's just call it the magic at the back end happens. Then it gives you what you want, which is this, right? You can do this daily, weekly, monthly, and all those kind of things. Then the power dashboards at different levels, right? Just the framework, right? At its basic. So this is at an aggregated basics, which is the most functional for many people, because we don't report data at a client level, right? Don't forget to raise your hand. I'm just going to go quickly through some examples, as we discussed in the prior conversation, around the areas that we can all share, where we can demonstrate impact, right, of some of this work. So I think we've talked about M&E, I think we've talked about data analytics, we've talked about deep dive analytics, we've talked about GIS, we've talked about all those kind of things. We're just giving general approaches of how things have worked elsewhere, right? So if we, what you call this? Cite your program and all those kind of things, great. If we don't, next time, right? The issue here was the need to improve case finding through HIV real-time testing. So the problem was that the program, right, I think this South Africa, where they're working with the community partners, which is the majority of the people here, right? So those that don't understand how this works. when USAID or a CDC has got money to do some particular work, they can do two types of things with community partners. They can have a DSD program where one implementing partner is the lead. They've got a little consortium, but in that, they divide the work and they actually go and subcontract a community partner, right, to actually do the community work. So there's no free lunch, right, with those guys, right? So everyone get targets, right? That's how it is, right? So whether you're a community partner or whatever it is, you get targets, right? You need to achieve this yield. You need to achieve this number of people tested. You need to, and all those kind of things, right? Or they can actually have a mechanism where they can actually subcontract community partners directly, right? And in this context, the chief of party of the district is amongst us, which is Dr. Chuka sitting there, I saw him, right? They subcontracted an ex-local partner that was doing the community work, but as you see, their yield fell way below the target. The intervention, more or less, was to use a mobile health application app that is called Links. What it just does that it's for every test that you test in the community, it geolocates. I'm trying to make it the most basic of the value. So it geolocates, it tells you that the person doing the counseling is taking how long, for example, right? Back then, it used to have a timer, so innovations evolve. It used to have a timer, when the counselor doing it, you'd press something, then it times you so that you're not too fast, too slow, and all those kind of things. Then it's useless, right, if you, let's say your client is positive, right? For the people that work in this world, if the client is positive after 11 minutes, there's no need to waste the other 20 minutes waiting for this thing, right? We already know that it's positive, it's positive. You don't have to follow the timer. So there's certain SOPs and protocols that were then removed. But the key essence of this whole thing was the heat mapping exercise that was done, right? Just based on the people that are actually turning out positive and those that are turning out negative, and just mapping that on top of a community and actually understanding where your most hotspots are when it comes to the people that are actually new infections in a way. Add that with recency testing, even better. But what it did at the end of the day is that local partner, by just using this Links app, right, for their case finding and not wasting time in the different places that they actually need to go and just focusing in the areas where we would give them high yield based on the data, moved it to 27% in that financial year. Right. Another example that I think that has been exhaustive today, don't look at this, is the epidemic control rooms that we've talked about at length. And instead of just presenting data, I thought it's good to have a conversation about the key things that are necessary for this to work, right? There's a lot of things that are not here that have been spoken by others when you spoke about how do we bring different stakeholders that are equally invested in the program success to be in one place, look at the same data source, and actually make the correct inferences about good performance. Let's start with good performance. How to capture best practices. How to triangulate best practices to other implementing partners or other geographic areas, right? So there's goodness in this, right? The best practices. Why are we doing so well? We're performing at ×3, right? And all those kind of things. What are the teams doing? How do we document these best practices, right? Then, where there are big gaps, the first litmus to a gap is you're way below the target, right? You start with a big annual overall target. Oh, you need to test 100,000 this year. Then you say, okay, for us to meet 100,000, how much do we need to test every month? So you probably divide that by 12. Then you say, this is our monthly target. Then you say, oh, how much do we need to do weekly? Let's divide this by 4. Then how much do we need to do this daily? How do we transgress this daily to the different facilities that we look after? Basic, right? But the key thing is the monitoring of those numbers in these forums. Right? That's where the litmus comes to say, guys, we are bleeding this treatment codes. People are not coming to pick up the medication. Why? Right? Then we try to understand the problem. Then together, by looking at the same data, the different stakeholders, when I say stakeholders, half the time I'm thinking Ministry of Health, the implementing partner, and the funder. You don't know where great ideas come from, right? So trying to put those people in one place is one of the most difficult things to do, right? Right? So and also understanding that the data being powered here, what's the source of that data? Are we all aligned with that source as the reference source of data? Does that make sense? Right. There's a big requirement of behavior change, right, and leadership that we talked at different levels. Highly central level, facility level, regional level, right? Some countries, you got provinces and you got districts and the likes, but whichever way, how you demarcate it, right, that is essential, right? This thing cannot be successful if there is one gap in a leader that does not believe that this is the correct way of reviewing this work, right? Indicators, I think we talked about, right? Then an understanding about what gets into a daily review meeting, right? Remember, daily means Monday, and I still need to go and see my patients. Huh? Daily means Monday, and I still need to go capture my data. That's daily. Daily means Monday, but I still need to do my M&E work. Daily means Monday, but I still need to go do demand creation for testing, right? So, short, right? Dr. Chuka, how long are your daily review meetings in Eslanzeni, in Mpumalanga? 1 hour. So every day, right, they start at 7:30 for that 1 hour and everyone goes to work, right? You cannot have this long because people have to go to work, right? It's a data program, but it's not a data program. It's a patient-centered program, right? Data is a facilitator. It's a lubricant for what we're doing. Make sense? Right? Then you got weekly review meetings, and on the weekly review meeting, that's when we get other people, right? You get your DOH to be part of that, and we get to your stakeholder, the principals more or less. But on the daily, they are down there at facility level, right? So back then, before COVID, we used to do this, we did most of this physically, create the NEF centers, that's what they call them in this country, or district situation room in Zambia, where people from the different places would meet in this one place and the likes. We all look at data, we argue out, agree on interventions and the likes. Then COVID came through, right? And remember the investments of setting up the physical situation rooms, right? You got all these big screens, you've got all those mics, you got this, you got people logging in and all those kind of things. All that more or less died in a day, right? How do we now continue running these programs and doing the situation rooms when we can't meet? Then we had to change this, and we had to go to the virtual situation rooms, right? Very difficult, because your other stakeholders, let's say Ministry of Health and this and that, if they have their own IT issues that you do not have control over, they can't join, right? Back then, you're meeting physically. Right, in more or less, we set up all the situation rooms in the Ministry of Health spaces, right? So it was easier to do them. So IT, infrastructure, and the likes, challenging when it's virtual, but can be done. I think we've been doing it successfully now for the last 8-9 months, the virtual situation rooms. And it's even more helpful that you can even get a broader audience. There's times that we've even invited some of our Washington folks to join some of these meetings, or some of the implementing partners that actually want to learn how to run it, right? So you get partners to say, no, we're doing this, but we want to see how you actually run it on a daily basis, right? For it to work, some of the decisions was, this cannot be an SI and M&E-led conversation, right? Because it becomes people that understand data talking to themselves, right? That's what usually happens. So all these are actually led by the chief of party of that program, right? So the chief of party of that program is the main custodian of this. That way, if the boss is there running this, trust me, you will show up at 8. Right? And they are leading the conversation. What should be done? What should be done? And all those kind of things. So that capacitation of our chief of parties, deputy chief of parties, and our technical specialists to actually understand the insights of what's coming here is key. Remember, this is just data, but it's data for action that, that's the key thing. So Art and them, they spend a long time creating data for action frameworks where it can actually be a navigator to say, oh, if my data and my performance is looking like this, what do I need to go and do in the program? Then it tells you, go and check 1, 2, 3, 4, 5. As a manual, as an SOP to the starting points. if your numbers is not, for this indicator, if your number is not performing, what do you do in the program? 1, 2, 3, 4, 5, 6, 7, right? And the idea, I mean, that's the whole idea, right? To have a menu, to be able to say, you know what, it's red, it means I can't go, right? That's what it is, this data. It's a GPS, right? Do I go, do I stop, do I go left, do I go right? Do I go backwards, or I'm paralyzed, I guess I have to park, right? That's what it does. But you're not doing it alone. So here, I'm not going through too much. This is some of the impact that was shown, right, when we started instituting this work, right? I think there's another slide that further talks about the evolution, right? Starting with the situation rooms or the data review forums, then went further to have a DOH running the situation rooms, right, and capacitating them to actually do it further, then consolidating and including everyone and actually starting to do more deep dive analytics and predictive work. And we'll just pick the indicator TXU to just show that from Q1, Q2, Q3, Q4, the impact, right? So this is not exclusive impact to SI, right? Remember, the work has to happen in the facility, right? But it's exclusive impact to the different programming approaches and targeted approach, and using our HRH resources and our finances in a clever way, guided by this data, to be able to get to that number, right? Make sense? Right? I'll be a little bit quick now. So I think this is, so this that I'm going through, so that you don't get lost, are examples of the different things there, right? You get my point? We've just done the situation rooms, right? We're going to talk about EMRs. We're going to talk about, these are the things we're talking about, right? Make sense? So we've talked about case finding and GIS work. We've talked about operationalizing situation rooms. Maybe Dr. Chuka, could you tell us one of the key things that you did with the Ministry of Health to be able to get them on board, right? To buy in to actually saying, let's do situation rooms together instead of just the implementing partner, and USAID as well. I think that's important for from a practical operationalization point. All right. So yeah, I know most of you, so I'm going to pick someone else.
All right, so good morning again. I'm Chuka Onaga. I'm the Chief Technical Specialist at Right to Care. And like you said, I run one of the programs. In terms of the situation rooms, obviously the first step, like any change management he was talking about, is to make people uncomfortable with the status quo. So we started feeding them with data about how there is a performance gap, and then we started introducing them to what is possible under this whole paradigm shift, so to speak, because they were used to things being either paper-based or using a form of drive or Excel sheets to do their data collation and collection and validation. And then along the way, because it's difficult to convince somebody to want something if the person has not experienced it, we were able to bring them to the head office, Right to Care head office, at a point where they saw it live. And then we went back and started working with them to understand the different indicators, what they mean, how you cannot manage a program without really understanding the different indicators, and basically train them on the processes and all of that. At the time, of course, we were able to fund completely using USAID funding the whole value chain of installation of situation rooms. And obviously, we also started sharing results. You don't ask somebody to start working on something without giving positive feedback. So the sharing of positive results kind of spurred them on, and they embrace it completely. And I think in the end, it's worked out for everyone, because that particular district was one of the first, one of the few to graduate on the 90 units project. Obviously, now everybody is chasing the next target, which is 95, 95, 95. So I don't know if I've responded to your query.
Oh, thank you. So we spoke about that. Then, same thing in Nigeria. It was more or less more on deep dive analytics and doing more value-add analytics based on the different data sets that we got our hands off and the problem that they actually articulated, but also EMR optimization and also supporting of the high-frequency reporting. Sites, more or less similar work in Malawi as well, around optimizing and scaling up of EMRs, creating SOPs, training how to use them, but also making sure that they actually power different dashboards, more or less for decision making. So I'll not repeat. I think this is more or less similar to what I've spoken to already. Then I think I've spoken about the value-add analytics. There's a session tomorrow where we're going to actually be going more around the insights, around when do you actually get to say this problem or this challenge or this performance really needs us to actually do more of deep dive analytics, right? Then in that forum, we can talk a little bit more about predictive modeling in its essence or generic form, but actually translating some of that client phenotyping or predictive modeling into more machine learning algorithms and some of the work that we have done across the region around machine learning as well. But I think we'll go into that tomorrow, right? So there's a session on analytics that we'll talk about that and give a lot of examples, right? But the key thing is that I think there's been a whole lot of work done around this. But for the group that's here, I think the key thing is how do we diagnose when deep dive analytics are needed, right? What are the prerequisites to do deep dive analytics? What kind of data is required, right? What kind of skills and capacity are required? How do we actually define the question, for example, right? To say, okay, the chief of party has raised their hand, we need support, we need to get more insights around this problem. It's more the approach than what we have done. Right? Let's remember that, right? It's more the approach, right? These are just examples, but it's about the approach, right? I think this we spoke about, right? The power and the need of centralized data house. If, depending on the governance laws in your country, I think there is good probabilistic matching algorithms that are in place that we've actually used to be able to match data from different places, right? To be in one place and create a centralized record, either on a server or on a cloud, but then power different, what you call this? Power different dashboards and all those kind of things to be able to make sure that you can automate or customize these dashboards. It will provide data in real time to the program, but also you can pull that data out of this warehouse, right, to another statistical tool. It could be SaaS, could be, Stata, to actually do more deep dive analytics if you have defined the need for it, right? And our role and what we have done across the region as well is to support different implementing partners that need support at different levels, right? So if they need help with supporting setup of situation rooms, we do that. If they need help with understanding and doing deep dive analytics, we do that. If they need help with creating customized dashboards and reporting and the likes, we do that. If they need GIS support to be able to do certain things, more or less, we support that. That's our role within the ASAP program, right? That's what we do in the ASAP program. It's to support community partners, support DSD partners, to make sure that there is that fluidity at different levels, right? It's not everything that people need, but based on their gaps and their challenges, right? It could be at a separate level that we actually support. That's what we do as part of the consortium partner for ASAP, right? Then I think we're going to now go down into, if we've got 5-10 minutes, because I think we got 45 minutes left, or do we go into the next presentations? There are two key technical presentations, right? Then we have one last answer and section that we can actually go through. Someone has to make a decision. Someone? Presentations. Okay, decision made. So Anati, come through. Then the guys online, we're capturing. We're going to have one discussion at the end. So Karina, with an Indonesian example, will talk. Then there's Abby and there's Stanley. And raise your hand if you've got a problem. Something's unclear.
Okay, good morning, everyone. My name is Anati. I'm with Ratike, MNE. Yeah, I'm just gonna. Thank you. That's better. So I'm just gonna take from where Prof. Pedro has stopped and then go into details in explaining how you gather requirements for creating dashboards for data demand and data use. Okay. So firstly, I'm just gonna briefly define what data demand is and data use. Well, I'm sure most of us know what that is, but I'm just gonna give a brief definition of that. And then also go to explaining how exactly do you gather requirements in creating data collection and data use tools, which are dashboards that will help you in decision making. Also, after that, I'm gonna talk about documenting the specifications after sitting down with a group of people, sharing ideas and posing questions, and then you put that in a document. That's the document that you actually submit or give it to your IT people, which are your developers. Then they take that as a manual or as a guide on how to create the dashboard and what exactly is needed by the users or the program people. And then again, after the dashboard has been created, we go through what is called user acceptance testing. We test if the dashboard that has been created is accepted by the user. Is it according to what was discussed before? Is it according to the specifications that were documented by the users and program people? So basically what I'm doing, if you remember, Prof mentioned the 4 strategic pillars, which is M&E, business solution and innovations, data analytics, GIS and planning. So basically what I'm going through right now is the part of business innovations and business solutions and innovations. Just to briefly talk about data demand. So when you're demanding, there's demand for data, that's when the decision makers, that is the program people, specified what kind of information they need to inform the decision-making process. And then they seek it out. And then after that, after they've seeked out that information, they then decide on what to do with that information. That's when the data use comes in. Then that's when you actually review the data to inform recommendations on how to allocate the resources, how to monitor the project or the program, how to actually create, revise a program strategic plan and inform policy. I'm gonna be a bit quick because of time. And then again, just to touch on what determines data demand. If we look at this diagram here, we've got factors that are affecting decision-making process. We've got these 3 factors here, determinants. We've got organizational determinants, which are relating to organizational context that supports data collection and availability and eventually use of data. For example, this talks to the identified procedures, roles and responsibilities of those who collect and analyze data and later on disseminate the information that they've found after using the data. And then we go talk about the technical determinants of data demand. This one refers to the technical aspect of data collection, as well as tools such as collection processes, methods, as well as forms that we use for collecting data. And then the last one is behavioral determinants, which refers to the behavior of individuals who produce and use data. So this covers the skills of people that are collecting data as well as the ones that are using data. It talks about the values, the attitudes, as well as the motivation. So this is also important so that you know that people that are actually collecting this data and have the right skill set so that they know what to do and what to collect, so that we make sure that the data that we collect is of quality and we report on it and we make good decisions based on what we know that it's for sure of quality. And then we look at the conceptual framework of what I've just explained now. If we look at this diagram here, we start, it's a cycle. So this cycle basically tells you that we demand data here. So after we demand the information, we actually go on to collect it. After collecting it, it becomes available. When it's available and stored somewhere, that's when we use it. When we talk about utilization, that's when we actually put it on dashboards as well as other visualization platforms that we have to actually use the information to make decisions and to inform some policies as well as guidelines to the program people. And eventually we will get an improved health system. Okay, so yes. Now this is the main part that I will be focused. I was just passing through on data demand and data use. So basically what I'm gonna touch on is how to develop those tools to monitor the programs. So we use dashboard. So how do you then collect information in order for you to develop those effective dashboards to help your program? Okay, so we've got a process. I think Prof has mentioned before that. We've got a process of gathering information. That's where you've got your data analyst. The data analyst goes out to sit with the program people, M&E, to actually understand what exactly they need. What do they want from the system they want built? The system is the dashboard that I'm referring to. So that process is called user requirement specification gathering. We're gathering that information so that we know that the dashboard that we are making is actually talking to the needs of the program people as well as the users. So as point number 1 there says, it describes the business needs. So the business can be M&E people and program people. So that's the business I'm referring to here. So the user specifications are written right at the beginning of the development of the dashboard. So you cannot develop a dashboard if you don't have the user requirements specifications, because that's your guide on what exactly is needed on the dashboard. So it's it's developed early in the process, typically before the system is even created. So who sits in this meeting or development of URS? It's the owner of the system. So the owner of the system is the program people, and M&E as well, and then the end users, and also we need to have some input from quality assurance to make sure that what is being developed is of quality. So here we've got a diagram that shows the process of dashboard development. So we start here with the project startup. So that's when the idea comes in to say, okay, we've got a lot of data that's sitting in a database somewhere or in an Excel spreadsheet. So we just need to, because it doesn't make sense now. I'm just seeing a lot of columns that don't make sense. So what we need to do is to actually take this data and put it in a dashboard form so that we can understand what exactly it means, looking at the visuals. So that's the startup of the project. That's when it comes in. So say, okay, we're going to develop a dashboard. And then the business requirement gathering, that's when where it comes in, which is the URS gathering. You design sitting with all these people that I've mentioned. And then the design is now there after documenting all those needs that need to be put in place in order to make a useful dashboard. And then here it becomes implemented. After the design, which is the document that has the specifications, it's been handed over to the developers to actually develop the dashboard. That's where the implementation takes place. After that, that's when now it goes into testing. The developers will then say, okay, we are done with the dashboard that was requested. Now it goes into QA, which is quality assurance, to make sure that they followed exactly what was written on the user requirement specification document. So the quality assurance people do their testing on the system to make sure that it meets the requirements. After that, there is a lot of back and forth that happens here at this stage, because if the quality assurance team tests the system and find that it's not according to what was specified in the document, then they go back to the implementation, which is the developers, to say, no, here you need to do this, you need to do it like this. It's not how you have done it, so change this and this. They do that, and then it goes back to testing again. So that's why we've got these other components here under these two blocks. So again, there are a lot of changes that are made based on what is possible and what's not possible. So you must remember that when you are a program person or M&E, you've got a lot of, I don't want to say imagination, but you've got a lot of ideas that you have. So some of those ideas might not be possible for the developer to actually put them in place as what you are requiring. So that's when now the people that are testing, we go back, talk to the management to say, no, we need to change this. That's where the change request comes in. We change what was initially there to say, no, let's make it like this according to what was said by the developers, to say, okay, this is possible, this is not possible. So that's why we've got a lot of process happening here. But after that has been confirmed and say, okay, we're happy, then now the UAT team signs off to say, okay, we're done with the process, with the testing, then the project is complete. Then it is signed off to the users, and then they start using the dashboard. So that is why the URS is important, because it's guiding the way the dashboard is to be made and how effective it is. It's dependent on the URS, which is the user requirement specification. So why is it actually important? So the benefits of it improves the satisfaction of the stakeholders, because during the meeting, gathering those requirements, so the stakeholders, they also putting down their ideas and all sorts of things. So the URS will be what the developers will look at to make sure that they are developing exactly what the stakeholders have mentioned or what they've put down into those requirements. So one of the benefits is that it improves the stakeholder satisfaction, so they become satisfied with the product, and then it also increases the project success. We know that we need to plan before you actually do any project. So this is, the URS is sort of like a plan as well it's a plan of how the dashboard is going to be developed and when and all of those things and what is going to be used. So if you've got a plan in place, it means that you've got a high rate of success in your project, you can be sure that, okay, it's going to be successful if what has been put down is followed correctly. Also, it reduces the project costs, because if you've got everything written down and clearly stated, you will not have to waste resources doing things and then later finding out that actually we don't need this, let's go back and do this. Or maybe you find that, okay, no, we've used a wrong database or whatever, an expensive database that is not even used and stuff like that, then that's where it comes in. So that's where the specifications comes in, where you say, okay, this is the database we're gonna be needing, why, and yeah, you make those decisions instead of spending money on things that you later find out that they're not useful. Okay. Okay, I've already talked to a lot of things here to say, okay, it's a group of people sitting down, putting ideas of what they want to see on the dashboard and how each person brings their idea and how it actually fits in together to give an effective dashboard that will eventually help in decision making. So some of the things that are discussed in that meeting, where you gather requirements, you discuss what database, visuals, extracts, or online system you want. Do you have the data already sitting in a database somewhere, or is it in a paper somewhere? So those are the things that are discussed in gathering those requirements. Also building off the business models, the data dictionary, how it's going to be built and stuff like that. So it is very important that when you are having this initial meeting with the business analyst, the business analyst is the person who actually documents all of this. So it's very important that the foundation is very clear and everything is stated clearly so that you get what you want at the end of the day. So this, so you need to make sure that you answer all these questions. So this is the document. It's a handout that will be shared on a folder that every one of you here will be able to access. These are just questions that might guide you to actually gather information before you actually start building a dashboard. So first of all, the business analyst will sit down to say, okay, fine. So what the business analyst does is a person between the developers and the users, the program people and M&E. So the business analyst will put whatever that the business, which is the M&E and program people, are saying, translate it into a language that the programmers, no, let me not use that word, the developers will understand in order to produce the dashboard that is needed. So the BA, which is the business analyst, will sit down, ask these questions. How do you hope this will help you? What questions are you trying to answer with the data? What problem are you trying to solve? So they need to understand all of those, they need to have all of that information in order for them to actually also recommend to say, okay, here's a solution we have for you. We can develop something like this for you to be able to answer these questions. For example, you might, as programmers or program people and M&E, you might not know what solution you need, but you might have ideas, or maybe you just have only problems. You don't have solutions. So the business solution innovation team, which includes the business analyst as well as the developers of the system, they will help you with that. So the BA will ask these questions in order to come up with the solution. So in this case, the solution that they will come up with will be a dashboard that will be helpful to you to make decisions. So these will be shared. All of these questions are there, so you will go through them. Unfortunately, we don't have enough time to do that now. But all of this information is in that document. So we've got business requirements. So that's when the BA wants to understand who's the target audience of the dashboard. That is very important so that they know how exactly the dashboard will be built. Who is it targeted for? What is the target audience? And who's the business owner? Who's owning the dashboard? Is it only the M&E people, or it will go to program people? At the end of the day, the technical owner, and also they want to know what problem the dashboard is aiming to address, what actions are the users trying to take based on this data they want to see on the dashboard. Also, we've got technical questions. The BA will ask you who should have access to this data. As Prof has mentioned, we've got some POPI Acts and all of those things, the security measures that are in place, because we're dealing with people's data as well, as because some data is actually at patient level. So you want to know who's going to have access to the data so that you know that you don't give out people's information just anyhow. So this is very important. You need to specify who has the access to the data. Are there any existing reports that you have that you want this dashboard that you want we're going to build for you? Are there any existing report we can use, modify or enhance, or we're just starting from scratch? Or we're just giving you a solution to say, okay, we're starting from scratch, we don't have anything, but if you've got things that you've built already that maybe are not helpful, then you'll be like, okay, we've got these, then we're gonna take them and build the dashboard off of those existing reports. And then what indicators are going to be on the dashboard, what measures, what metrics are going to be used. And the question also you want to answer is, where is the data sitting? I've already mentioned that. Is it on a database somewhere? What's the data? So is it on Excel? Is it on a paper, just a register at a clinic? So that is all the information you need to provide in order to build a dashboard that will answer the questions that you have. Okay. Now, after answering those questions, we have another document that is called the statement, user requirement statement. So those, after answering all those questions, the BA will take all the answers they got from the program people as well as M&E. They put them here in a language that will be understood by the developers, people that will be developing the system, which is the dashboard itself. Then they put it here in that language. For example, here, if we look at this, this is also a handout that will be shared with the whole group so that you look at it in details, and actually you can maybe reuse this template when you are doing your, or documenting your URS. So firstly, okay, it's just a standard document where you have all the people that will be reviewing the document. You've got your business analyst, the person actually documenting, the project manager, M&E manager, data quality reporting manager, and the BSI, which is Business Solution Innovations Manager. You also need to say what's the purpose of this document, or the purpose of this dashboard that you're creating, and then the objectives as well as the scope. But what we're more interested in is this part. This is the part that talks to the developers, people that are developing the dashboard. The visuals. You've got a report number there. It tells you what report number is this that you're trying to build. Then you write a number there, report name. Then you just say maybe it's a trend analysis, or maybe it's just achievement percentage of certain indicators. You just write what the name of the report should be and the report type as well. We've got, because reports can be in a form of graphs and as well as form of tables. So you have to specify whether it's a table or a graph. If it's a graph, what type of graph is that? Art will get into details on how to choosing graphs based on the data that you have, which ones are appropriate and the right charts to visualize your data. So that's when you specify here to say, no, for this report that I'm building here, or for this, I want on the dashboard to see a bar graph. You write here that this is a bar graph I want to see. Of course, it's going to be high priority. The publishing platform. So since I've mentioned that we've got on the report, you either have a table or a graph. So the table is the static form of your report. So you specify here if it's static. If it's dynamic, that's where we talk about your pie charts, bar graphs, and all those type of charts. So in the data sort, you need to specify here if it's an Excel file or whatever tool that you have that you put your data in. And then an example here, that's where you paste an example of the chart that you want to see on the dashboard. You paste it here. Like I said, Art will go into details on the examples of charts and everything that you can use while trying to design the dashboard that you want to see. Also here at the bottom, you need to also specify to the developer, because to them this is a foreign language. They don't understand your HTS, TST, and HTS pause. They won't understand. They will just do something that, will not make sense. So you need to specify to them to say, okay, on my graph, I want to see testing. I want to see the target of testing. I want to see positives. I want to see TX new, as well as the TX new target, yield, as well as linkage. So for the yield, they don't know what yield is. So you need to say to them, okay, this is a calculation, a percentage, where you take the number of positive divided by the number of people that have tested. Then it gives you the yield, which is the percentage. So all of that information is required for them to actually produce or develop a meaningful dashboard that will help you at the end of the day to make decisions. Also, this will be given out as a handout so that you have a look at it. It might be useful. So now we have, okay, let me go back here. So this is done, documented, and now the BA now takes this to the developers to say, here's a project, go through this is what you need to develop. They develop that, and then it goes to testing. Like I explained earlier, it goes to testing, and this is what is called now user acceptance testing. So here, what is being done is verifying that the user solution, or which is the dashboard, works for the user before it is even signed off to the user. So why are we doing this? We do this to assess if the system or the dashboard can support the day-to-day business or user operations as expected, as according to the URS that was developed before. So that's why we do this. So this is the process of actually executing the UAT, which is a user acceptance testing. First, before you start your test, you need to plan your UAT. You need to define the scope of the UAT. You need to identify the scenarios. You need to review the URS that was given to the developer. You need to also have use cases. For example, if you were trying to develop a dashboard for a certain country with regions or provinces. So you need to look at your data to say, okay, I'm gonna take maybe 3 districts from each province. So those are my use cases that I'm going to use to test to see if everything is there or everything is working according to what was put down in the specifications. So you need to also look at the user interface. The user interface is as the actual dashboard itself. You need to actually document the UAT test. You need to have a document where you're going to write down the UAT results after executing it. Did you find any defects on the system? If there are any defects, you write that down. That will go back to the developers to say, fix this and make it look like this. After it is fixed, then it is tested again to make sure that everything is according to the URS, and then the UAT sign-off. So this sign-off is done by the users of the system. So the users would be M&E or the program people. When they say that, okay, we've done our test as users, we are happy with the system, it's exactly how we have described it, they've done what we want, it's answering all the questions that we have, then you sign it off to say, okay, now we can take our product, we are happy, then that's that, the project is done, it's completed. If there are any changes, you find that, okay, as a user, you want to make changes to the system, you find, okay, it's not working for us anymore here, we need to add this and that. There's a process called change request development. That's where you're changing the request that you had made before. You are changing what was on the user requirements. You put that down on a change request, you send it again to the people that were developing so that they make that change to the dashboard. It's also a process, but it's not as bad as it sounds. So this is the team. So the UAT is actually, it's performed by a team. It's not only the users, it's a team. We've got a team here. It's the project manager, the business analyst, the developers, people who are actually making the dashboards, the test management, your quality assurance people, and then we've got IT operations, we've got your UAT lead. This is the person who actually understands the business and the technical terms of the project. The person who knows what yield is, what linkage is, so that when they see that something does not make sense on the visuals that are on the dashboard, they say, okay, no, this doesn't make sense. Fix this so that it talks to the program. And then also the users would be maybe people at lower level at the ground to say, actually, this does not happen at the ground, so we can change this to this, or maybe no, it talks to exactly the problem that we're having on the ground, so it's helping the whole system. So this is the whole team that makes sure that whatever that was developed or the dashboard that was developed, it's addressing the problem, and also it's helping the stakeholders make some decisions based on the data that was initially collected and all of that. Okay, I'm done. Any questions? Okay.
I think we have 10 minutes left. Hold on. I think we've got 10 minutes left, and maybe we can start our discussion session. I think to just prep for tomorrow, I think Art is going to take us through the whole dashboards implementation. Andre also is going to help us with that. Then after that, we're going to do the data analytics session and deep dive analytics. Then after that, we're going to do the GIS spatial modeling and the practical examples using in the real-time systems, not presentation. We're going to go into the systems, articulate a problem together. We go into GIAC systems for GIS spatial modeling. I think that's the essence of tomorrow, the practicalization of what we've actually mentioned. I think that's the key thing we're doing tomorrow, so that you are aware what's happening tomorrow. Then I think we have 10 minutes. I think the key essence from Anati to just reflect why we now have that business solutions and innovations group in-house. You can spend 2 months developing things for a program, then when you come and present, they'll tell you, you must be out of your mind. This is not what we said. This is not what we need. Can you please, you can spend 2 years doing this, right? So this requirements, documentation, URS, and approach gets to get the sign off. You know, you got a clear expectation of what you're getting so that everyone is on the same place. Otherwise, 3/4 of business analysts, those that understand them, they come from the banks. The people that we hire that do business analysts, we rob them from the banks. They've got no prior understanding of what TXNU is, right? So that training and institutionalizing them into health is extremely important. Then some challenges you're going to have, it's the better they get, the turnover rate is very high. You can't keep them seated, right? So they're resigning every other day, right? Because you're competing with bankers, you're competing with actuarial companies, because these are the kind of people that actually do this kind of work, right, at the back end of it, right? So it's something that for most implementing partners, they don't want to do in-house. They rather outsource it from ASAP, right? That is done for them, then it's done, they let it go, then it runs for them, right? I think that's the whole element of some of the elements and training and support that we're giving through ASAP around this whole entire process. So it looks techy, and you don't have to be worried about it. You just see the magic of your outputs being delivered, right? Then who's got maybe 3 or 4 burning issues, something we can discuss? Someone has to select. So 1, who else? 2, 3 at the back. 2 more.
I can start?
Go ahead.
Okay, thank you for the presentations. I'm Victoria from Malawi. On the just ended presentation, my concern as a local partner is that most of the resources that are being talked about, we don't really have them. So like the business development, what, and then there's the quality assurance, and then the time frame, and then the resources. We don't really have those things. So yes. I'm wondering, because some of those things, you have to be the M&E, the programs, and then the business specialist, and then the quality on your own, right? So ultimately, I just wanted to, we're going to outsource probably when we want to have a dashboard. And you have these consultants that come in giving you these technical terms we don't even really understand, you know?
Neither do I.
So what would want to really know? Yeah. What we want to, for me, what my interest is what are some of the key things that I need to know that this is going to be a good dashboard for the requirements that I have? Like what are some of the do's or the don'ts, or you definitely need to have this, you definitely need to have this as you're making decisions. Because outside of that, then the rest, I don't even know where to start.
Perfect.
Thank you.
So you need to come to tomorrow's session. So Andre and Art are exactly going to be answering exactly what you asked, right? That's the do's, the don'ts, the needs, why drop this, why not keep this. But in terms of the resources, I think that I can answer. So there's been an evolution within PEPFAR, I think, so that I give you some of the history, right? In a sense that there is a more cohesion around creation of more global mechanisms, that it has always been very specific to care and treatment, but they're very specific to data demand, utilization, approaches, data management systems, SI products, and the likes, right? And the key thing around this forum is that ASAP is one of those, right? So if you got a key need related to SI, based on the different things, we talked about a lot of things, right? From data tools to data centralization to dashboards. It could be data use. It could be setting up of data situation rooms. It could be lab tracking, all this and this. All this, there has to be a need for adding efficiencies. Could be basic reporting, right? How do we automate reporting, right? How do we, that's the whole thing. Could be just be that, right? But the key thing is that through ASAP, that's where the support is. That's why they've got banners of ASAP all over, right? So if you got set up, so you don't have to have an establishment where you got a Department of Business Solutions and Innovations, GIS unit, or data analytics unit, and the likes, right? You probably don't need everything. Some people need everything, right? But the key thing is that ASAP can come and support you on data analytics if that's what you need, or more predictive modeling, more deep dive analytics, or you want to set up a situation room or data review forums down to your lowest, what do you call it, numerator? Like, yeah, right? If you want to do that, right, then your job is to say, I need situation rooms and all those kind of things. Then people come and talk to you to get more what you need. Then they present to you a solution and all those kind of things and how you can be supported, right? So you don't have to hire business analysts. We're just telling you what it takes, right, to get to saying, oh, this is the dashboards. Oh, I performed like this. My target is like this. I've got a gap of this and all those kind of things. Or a trend, or this and that. There is different people at the back end that get to produce this for you, right? You got developers, you've got business analysts, you are needed as M&E, there's the May guideline that needs to be incorporated, the technical people, your MOH, different stakeholders, all those have to be part of the mesh to get you what you need. But you need to be very clear about your ask. Does that make sense? You need to be clear about your ask. So it's not everything, and you're not running an SI portfolio or program. You're running care and treatment, DSD, TA, facility-based and community programs. That's the focus of the work, right? This is an aid to make it more efficient, less headachy, right? Is that a term? Right, that's the whole thing. That's what it does. So you know your spots of discomfort, right? Everyone will know their spots of discomfort. If your data is always wrong and you need to redo things, QA/QC, if that's the spot of support, that's your spot, right? If someone else, their spot is they want those fancy dashboards, but that's not your spot. You don't have to try to get things that are not your spot. Sava? There was a second question.
Thank you. My name is Jackson from Kenya. And just to pick on the fact that we are in a dynamic society currently, things keep on changing. And you can have a dashboard that is responding to your need now, but a month later, 2 months later, it's not responding to the need. So in the process of creation and in that particular protocol, how often do you get this feedback, and in terms of utilizing the feedback to keep on responding to our needs as it changes?
So is there anyone from USAID here? It's very good feedback you're giving. I hope they take it. Anyone from USAID to take that back to Washington? Right. So it's been our Achilles for the last 10, 15 years, right? All of us. We are all in that spot, right? Where things change by the day. The reporting requirements change by the day. You have done a whole exercise for the year of automating things. Then in the next cycle, you've got another 15 new indicators, right? And there are indicators that drop, and the frequency of the reporting has changed, the disaggregates have changed, and the likes. It's a challenge that we've all faced. But however, the way we have built the systems of the platform, we've made it to be an agile framework that is no longer as tedious, and it's also we don't have to panic, right? So you can see there's an element of all this that we call change request, right? So remember, whenever you ask anything to be changed or modified of dashboards or reports, there should be a documented change request that is filed in. Oh, I want to the disaggregates look like this, but we want to change these disaggregates to not uptake the new disaggregates that have come from USAID, right? And the likes, as an example, right? How do you do that? So we've created these agile platforms that developers don't have to stress, but they still stress, but your situation is not unique. We're all going through that. But as requirements and as USAID changes things, we have to comply, right? Okay. It says 1 minute, yeah? One question, then we're done. I've been told to stop, so one.
Michael from Kenya. I think those two good presentations are very good. One is just to understand the scope of your work, especially when it comes to business solutions that you spoke about. Is the scope within this region only, or it goes beyond? And then secondly...
Sorry, the question is the scope?
The scope of support. Is it only within the region, or is within your program only?
All right, okay.
And then earlier on we spoke about the virtual situation rooms, remember? And there was a point where you said sometimes you invite partners, you invite partners to come and sit in. Is that possible going forward? And if we want to learn, how can we do that? Those that are not within the region. Then last but not least is about client phenotyping. What type of data do you use? Did you say patient level or the aggregated data? And if patient level, then what does that mean in terms of data protection? Thank you.
Perfect. So it's 3 questions. I think we're going to end with that. Very nice questions, so we're going to be quite short. So I think the first question was, what's our regional footprint? Where do we work? So as you will learn through the whole week, so you need to understand, ask around, talk to me when I'm having coffee, what ASAP is. That's the first thing, right? Which regions have we worked before, and which regions are we going to be engaging to work on this? So in general, this approaches can be scaled up anywhere, and we've got as Right to Care, we've got a long-standing footprint, Sub-Saharan Africa, and also in Myanmar and Ukraine, we've done some of this work. But through ASAP, as we're a consortium part of ASAP, trust me, none of your countries are not a no-go area, right? That's the first thing. I think the second thing you asked was about the needs, what is needed for us to actually do deep dive analytics and actually do client phenotyping, right? For those that don't understand what client phenotyping, delete that word. It's how can we characterize our patients, right? And actually more or less create more likelihood scales around their characteristics about an event that will occur, especially a bad one, right? Right, are you most likely gonna be unsuppressed if you're a female and you wear glasses, right? That's what we're doing. That's right. That's client phenotyping, right? That's what it is, right? So that's a good starting point, and for you to go through that, you are needed tomorrow, right? So there's a whole session on client phenotyping, data analytics, what are the needs, and all those kind of things to be able to do that particular type of analytics, including the type of skills that are needed and capacitation areas that we've seen in the region when it comes to that. Then the last question was on? All right, what was the question? Oh, no, perfect. So, yeah, that you can do. So we run daily, weekly situation rooms, and we've had so many partners asking us, can we sit in? Let's see how it goes, and all those kind of things. And we believe that seeing is believing. Right, so if you come to one, you can actually see this impact and how it works and all those kind of things. And you can actually learn one key thing, that it is very possible for our technical, clinical teams to actually lead a situation room and not be led from the data people. Right? Data people can take over programs, They're dangerous. Right? Right? So you can capacitate your clinical people to run the situation room. And it's amazing because it presents a particular authority within the facilities we work in that, if they uptake these innovations, because data people, you're sold already. It's your other people, your other friends, right? Right. And it can be done, right? So that we can do, we can talk through the ASAP consortiums and we can organize that. All right.
Can I jump on that?
Sure.
Excellent. So let's give a huge round of applause for this amazing team.